Ladies and gentlemen, respected chief guests, Dr. M.B. Bharti, Dr. Gangadhar sir, members of the council, guest teachers, attendees, and our fellow PGs.
It is our greatest pleasure to welcome you all on this auspicious day to the AOIK Conference 2021, conducted by AOI Davangere Chapter in association with Department of ENT in JJMMC and SSIMS.
Let us start off this day with a prayer to the gods and goddesses of wisdom and knowledge to shower on their blessings on us on this day. We would like to invite Dr. Ima and Dr. Chaitra for the prayer song. Firstly, we would like to take this opportunity to call upon stage our guests.
Dr. K.S. Gangadhar, State President of AOI Karnataka.
Dr. M.B. Bharti, AOI National President-elect.
Dr. K.B. Chandrappa, President AOI Karnataka Davangere Chapter.
Dr. A.M. Shivkumar sir, Organizing Chairman of AOICON 2021.
Dr. K.P. Basivaraju, Organizing Secretary of AOI Karnataka Conference 2021 and HOD of Department of ENT, JJMMC.
Dr. Yogesha B.S., Joint Secretary of AOICON 2021 and Head of the Department of ENT in SS Institute of Medical Sciences.
Dr. Sridhar S., Secretary of AOI Karnataka.
Dr. M.B. Puttamadaya sir, Treasurer of AOIK.
Dr. Jyoti Swarup, President-elect of AOI Karnataka.
Sir, pakka off ಮಾಡ್ಕೊಂಬಿಡಿ ತೆಗೆದುಬಿಡಿ ಲಾಕ್ ಓಪನ್ ಮಾಡಿ pakka.
With this, we would like to start off the day with the prayer. Dr. Uma and Dr. Chaitra, please.
देवागणनायका पालका देवागणनायका पालका मूषक वाहन दोष विनाशा मूषक वाहन दोष विनाशा देवागणनायका पालका देवागणनायका पालका करुणदयासार गिरिकन्याकुमार करुणदयासार गिरिकन्याकुमार संगीतकाधार नीने दयासार संगीतकाधार नीने दयासार नी बंधु दय तोरु गौरी कुमारा नी बंधु दय तोरु गौरी कुमारा देवागणनायका पालका देवागणनायका गणनायका गणनायका पालका.
Now, we would like to take this opportunity once again to welcome our chief guest,
Dr. M.B. Bharati, who completed her UG and PG from BMC Bangalore. She's a senior professor and former head of the Department of ENT in JSS Medical College, Mysore. She is a national president-elect of AOI and received a multitude of training in both national and international levels, including a mini fellowship on robotics from Pertini Morgagni Hospital, Flori, Italy, expertise in head and neck oncology, otology, and skull-based surgery, as well as cochlear implants training from various centers across the country, with 40 plus publications in various reputed journals, both national and international, and many more awards and medals. We welcome you, ma'am.
Now, we would like to introduce to everyone Dr. K.S. Gangadhar sir, Professor and HOD of ENT, Shimoga Institute of Medical Sciences, Shimoga, presently President of AOI Karnataka. He finished his MS ENT from Government Medical College, Mysore. His former Principal Director of HIMS, Hassan and SIMS, Shimoga. He has more than 35 publications under his name. He's been awarded KK Ramalingam Gold Medal for Best PG Research in 1993 at South Zone Conference, Mysore. He's been awarded with ND Purushottam Gold Medal for Innovations in ENT in 2018 at SouthCon, Mandya. We welcome you, sir.
Now, we would like to call upon forward Dr. A.M. Shivakumar sir to address this meeting. Sir, please.
Good morning, everyone. It's a great privilege to be here on the stage at the state conference. We were supposed to conduct this conference in 2020. Somehow, because of Corona, it was postponed. There were a chance now. Use of a virtual conference and model. If you see the stage, if Gangadhar delivers his mask, ever smiling, efficient leader who led our association in the last 2 years as the president of Karnataka State Legislative Association or Association of Oral Radiology in Karnataka. I welcome you, sir. And when I say I, from now onwards, I mean B, that is AOIK Karnataka State Chapter, AOI Davangere Chapter. Next to Gangadhar, again I request Bharati to the mask. By a sheer activity, academic activity, simplicity and leadership quality, she is going to become the committed president of our national AOI. I welcome you. Again, Chandra, if you see the say again, Chandra looks like your fatherly figure on the stage, and that is why we have asked him to inaugurate this conference. And he is our president of our local branch. I heartily welcome you, sir. Dr. Jyoti Swarup, energetic person, our electric portfolio, ಮುಂದಿನ ಒಂದು ವರ್ಷದಲ್ಲಿ president elect of our association. I heartily welcome you, Dr. Jyoti Swarup. ಒಂದು ಸಣ್ಣ ಸ್ಥಳದಲ್ಲೇ ಅದ್ದೂರಿಯಾಗಿ 37ನೇ ಕಾನ್ಫರೆನ್ಸ್ ನಡೆಸಿದ Dr. Mohan Appaji, who is not here on this stage, but he is the past president of our association. I do welcome him to this August program. To run any association, along with the president, we know there are 2 more individuals who are equally responsible. There is one is the secretary Sridhar, another one is the treasurer Madaya. I really welcome you, sir. Next, again, state body means it's not just one meeting three. There will be a team of executive committee members. So I see few of the executive members in front of the stage. I really welcome them from my heart, Dr. Kailash Pujari and others. I will thank you in my meeting. If I don't invite or welcome my own colleagues of both the colleges and the members of AOI Davangere chapter. I do welcome you all. Next one. The delegates who are in front of their screen, PGs who are in this hall, and the technical persons who are involved in conducting this virtual conference. I welcome them all on behalf of your organization. Thank you.
Thank you, sir, for those kind words and for introducing all the members on the panel. We would also take this chance to welcome you as well, sir, Dr. A.M. Shivakumar, sir. Welcome to the gathering today, sir.
We'd like to now call upon all our guests on stage to kindly come forward to the lighting ceremony. Do light the lamp and shine light for this day's function going forward.
I am extremely sorry that I forgot one important personality who is the leader of the workforce behind this conference. That is Dr. K.P. Basavaraj. I really don't know why I missed him when I welcomed everyone. I do welcome Dr. K.P. Basavaraj, and I am really sorry for not mentioning your name as the organizing secretary. And Dr. Yogesh, who is the brain behind many things of this conference. I do welcome him. Thank you.
Thank you, sir. We would like to now call upon Dr. Gangadhar, sir, to attend this meeting with a few words. Sir, please.
Good morning, everybody. I'm happy we are able to conduct this conference today in spite of all the difficulties we faced. 2 years back, when this conference was awarded to Davangere, we were sure that they would conduct in a great way. But unfortunately, they could not because of the COVID situation. Somehow last year, they conducted only PG papers. This year, they were getting ready to conduct in a big way. But unfortunately, again, things did not favor them. In spite of that, we are here today conducting a conference in a hybrid mode. So I wish them all the success. So evening, we will have a discussion on interaction after the conference. Thank you. Thank you, one and all.
Thank you, sir. Now we'd like to call Dr. M.V. Bharti ma'am to address this gathering with a few words.
Namaskara. Actually, I feel very honored and privileged because this is my hometown and this is my husband's place also. So I'm very happy to be here in this conference as a chief guest. And I know like there were so many unforeseen scenarios which happened for the past 2 years. And we should not, look down upon ourselves when these unforeseen scenarios happen. We have to say it through it. So that is what the Davangere chapter has done it. So a big round of applause for them. Because last year also they conducted the PD papers, and this year they have shown themselves they wanted to have a virtual conference, but again because of the the laws which were enforced, so they had to shift to the online mode. So it's nice that at least the show should go on. It should never stop, whatever happens. And with this, because I represent the national AOI, I like to tell a few words. So the AOI also, in the last 2 years, we had so many online AOI webinars. Every Wednesday we conducted. Last year, AOI online webinar series 1. So we had eminent faculties, and this year we started with research methodology. Because see, what we do is, yeah, we are all surgeons, I know. We want to do surgeries. But that should not end there. We need to give more importance for the research. That is what is there in future for you youngsters, okay? So the research, so with that in mind, we started the research methodology webinar series in the last 2 months. Along with that, we had talk by the eminent people who are the innovators or who had maximum publications. So like that, we clubbed and we started having this. So in the next also, when I take over, we'll be giving more of this importance for the research, and we want to start fellowship programs under National AOI as well as research fund, and we want to have a separate academic body under AOI. So with all this, we will work ahead with the new team when the elections are going on. So the new team which comes elected in January will be having the results. So with that team we work like the past presidents and the past team which had worked and which had put AOI online. Like that, we want to progress the AOI and take it to a good height. So with this, I wish the Davangere team, AOI team, Dr. Basura, Dr. Shivkumar sir, Dr. Yogesh, and my senior friends, Dr. Mallikarjun, Dr. Loknath, and Dr. Chandrapa sir, and Dr. Renukananda sir, and Dr. Santosh. So, and all the other, I wish them a good luck in this conference. Thank you.
Thank you, ma'am, for those kind words. Now, we would like to call upon Dr. K.B. Chandrapa, sir, to address this gathering. Sir, please come forward. Sir, please.
AOI National, the AOI Karnataka, the AOI Davangere chapter, ಎಲ್ಲ ಪದಾಧಿಕಾರಿಗಳಿಗೂ ನನ್ನ ವಂದನೆಗಳು. ಇಲ್ಲಿ ಏನು ಮಾತಾಡುವಂಥ ವಿಚಾರಗಳು ನನ್ನ ಜೊತೆಗೆ ಏನು ಇಲ್ಲ. ಎಲ್ಲ ಅತಿಥಿಗಳಿಗೂ ಮತ್ತು ಸದಸ್ಯರಿಗೂ ನಾನು ವೆಲ್ಕಮ್ ಮಾಡಿ ನಾನು ಭಾಷೆ ಮುಗಿಸ್ತೇನೆ.
Now, we would like to call upon Dr. K.P. Basaraju sir to give us the vote of thanks.
Good morning, everybody. I take pleasure in giving thanks to all who worked here and come here. So first of all, I thank our chairman, Sri Dr. S.S. Shivshankarappaji, and our joint secretary and chairman of SSIMS Davangere, Sri S.S. Mallikarjun, and our principal, Sri S.P. Murugesh, and SSIMS principal, B.S. Prasad, and our director, administration, who all supported this conference. Because of this COVID and all, we have cut short this program into online mode. So I thank all of them for giving support to this AOICON 2021. So I also thank the AOIK Executive Committee and the members who have given us this opportunity for the last 2 years to conduct this conference, and I thank all the president and all the executive committee members of the AOI Karnataka chapter. I thank also the AOI Davangere members who have really worked hard, especially the scientific committee members who made this program. I think we'll have a good program till evening. The scientific committee members like Venkatesh, Santosh, Nagaraj, and Karthik, who have toiled because we are not that technically advanced as them. So they are the brain and heart of this conference, and they really done well. I thank them. So I thank also our postgraduates and our department staff who have done good work for the past few months and made this conference, I think it will be a good success. And I thank also the library and audiovisual people from since yesterday. They are toiling hard to make this into a good program. And all the, I thank also especially the pharmaceutical companies, especially the Sun Pharma people who have greatly supported this program. I thank also. I thank one and all. Thank you.
Thank you all the guests. Now we will be starting with the academic sessions for the day. I would like to kindly request everybody in the hall to keep their mobile in silent mode, because the sound from the phone can cause difficulties with the audio.
To start, our first session will be Dr. T. Manikam oration of the topic Thyroid Surgery Toolkit, focusing on reducing harm.
Dr. T. Manikam was one of the earliest ENT surgeons of our state. He did DLO from England and joined health services in Mysuru. He taught ENT in BMC as well as MMC colleges.
He was Dean of MMC and BMC in mid-60s. He strived hard to create ENT specialists by deputing medical officers in medical colleges. He was instrumental for starting postgraduate courses in government colleges.
We are grateful to him for his successful struggle, which enabled generations of Karnataka state students to get postgraduate degrees in our own state.
We would like to call upon Dr. Gangadhar, Professor and HOD of ENT, Shimoga Institute of Medical Sciences, Shimoga, to presently President of AOI Karnataka,
and Dr. M.B. Bharati, Senior Professor and former Head of Department of ENT in JSS Medical College, Mysuru, and AOI National President-elect, to helm this session as chairpersons and also to introduce to us the speakers for the session. Sir and ma'am, please.
ಹಂಗೆ ಸೈಡ್ಗೆ ಇರಲಿ ಅಲ್ವಾ, ಪಿಕ್ಚರ್ ಇನ್ ಪಿಕ್ಚರ್ ಬರುತ್ತಲ್ವಾ.
ಅಲ್ಲ ಇದು ಮೋಸ್ಟ್ಲಿ ಫುಲ್ ಸ್ಕ್ರೀನ್ ಆಗ್ಬೇಕು.
ಹಾಫ್ ಸ್ಕ್ರೀನ್ ಹಿಂಗೆ ಇರಲಿ,
ಹಂಗೆ ಇದೆ.
ಅವರಿಗೆ ಇದನ್ನ ಮಾತ್ರ ಲೈವ್ ಮಾಡುತ್ತೆ.
ಆಯ್ತಾಯ್ತು.
Good morning, everybody. So we are starting with the first session with the oration on Dr. T. Manikam oration. I am really happy to moderate this session because Dr. T. Manikam was one of the doyens of ENT in our state. Let me introduce that legendary personality to this audience. Dr. T. Manikam was one of the earliest ENT surgeons of Karnataka state. He did diploma DLO from England and joined health services in the state of Mysore. He taught ENT in Bangalore Medical College and Mysore Medical College. He was also dean of both the colleges in mid-60s. He strived hard to create ENT specialists by deputing medical officers in medical colleges. He was instrumental for starting postgraduate courses in government colleges. We are grateful to him for his successful struggle, which enabled generations of Karnataka state students to get postgraduate degrees in ENT in our own state. So I here present this oration to the audience.
Good morning, everyone. Now I'll be introducing Dr. Subhash Chandra Shetty, who has been awarded this oration. He is the current clinical director of oral head and neck surgery at CMDHV Auckland. Let's see his academic journey. He did in 1996 oral surgical training in JJMC Bangalore, and then later on he worked in St. John's Institute for 7 years. And during this time, he developed an interest in head and neck surgery. And then he went to Dunedin, New Zealand, where he undertook an intensive clinical supervised exposure in broader aspect of oral HNS. Then he got his FRACS degree. His main interests are rhinology and head and neck surgery, and he has an extensive experience of surgery for parotid and thyroid surgeries, and a member of multidisciplinary head and neck tumor clinic in Auckland. He has published over 40 peer-reviewed scientific papers and numerous presentations in international conferences. He is actively engaged in surgical research and is also interested in surgical education and healthcare leadership, and completed Harvard Healthcare Leadership Course, USA in 2017. Over to you, Dr. Subhash Chandra Shetty.
Can you see the slides, ma'am?
Yeah.
Okay, great. Thank you very much, everyone. It's a great pleasure to talk to you all, give a talk. This Davangere has been my alumni, and I'm really sincerely grateful to take this opportunity to express my gratitude to all of you, especially my teachers sitting in the audience, listening to their student talking. And really, it's an incomparable honor to deliver this year's T. Manikam oration. You may see a photograph of my beloved friend, Dr. Satyanarayana GV, who was my colleague and a student of JJMMC. He did his MS with me, and he passed away very recently for COVID. And I feel I should dedicate my work to him this morning. And also, thank you for introducing Dr. Manikam to me. I have heard so many Manikam's lecture in the past, but never heard such great things about him. That's fantastic. And Davangere has been a best learning years for me, and a lot of long-lasting memories and lifelong lessons, and also a lot of friends. And I'm really thankful to many people in the audience, especially Dr. Basuraju, Dr. Shivkumar sir, Dr. Loknath, Renukananda. They have been awesome teachers on their own right. And I also had an opportunity with Dr. Shankar, Dr. Sidlingappa, Dr. Veerana, and Dr. Marlaya. They're all gems also as a teacher. And I also recognize you, Dr. Bharti, and congratulations for being head of one of the biggest association in this world, ENT India, and Dr. Chandrapa, Dr. Gangadhar, Jyoti Swarup, and rest of the faculty there, and all postgraduate students. And Davangere has been a really academic force in the country and in the state for rejuvenating teaching and learning. And I like the mission of AOI under your leadership, Dr. Bharti, being focusing on research. That's the most important thing. I would like to talk about my experience in thyroid surgery, and also how to reduce harm in thyroid surgery by multidisciplinary involvement. I want to deal with this in 3 steps. The first one is just to recognize some aspect of thyroid in art and civilization, and also our journey and experience in decision making for difficult thyroids, and also a thyroid surgical toolkit. I want to accomplish this in next 30 to 40 minutes. Now, thyroid surgery is not a rare surgery or a new surgery. It was there since 1700s. The first successful thyroid surgery was done by this gentleman called Joseph Dessaulles in a hospital called Hotel Dieu in Paris. This was a pre-ether, pre-chloroform era, and he accomplished this surgery, and the patient lived for 30 more years. That was the first documented thyroid surgery. However, thyroid diseases were known to mankind for a long time, especially a goiter. The term, the gatta, comes from Latin, a drop or throat. And Chinese knew how to deal with the thyroid issues with the seaweed. And also Indians had called it as a galaganda in the second AD, so much earlier than anyone else. But we had northern India, Nepal, Uganda, and Ethiopia being a belt where iodine was deficient, so we saw quite a lot of thyroid diseases. This is one of our Ugandan hospital waiting area, outpatient waiting area. You can see that how big the thyroid can become. In the patients. Now, this particular person needs to be recognized because this gentleman was awarded Nobel Prize for his work on thyroid, and this is the first doctor in the world, first surgeon in the world to be awarded Nobel Prize. He not only contributed to thyroid surgery, he's a perpetual innovator, researcher, and also astute physician. And ultimately, he got the Nobel Prize. And in his Nobel Prize address, he talked about his series of 600 consecutive thyroidectomy. This was in 1910, before anesthetic era. And there was a single death and that was due to anesthetic complication. Please note that it was not due to surgical complications, it's due to anesthetic complications. Now, what's thyroid depicted in the art? If you see these pictures, this was excavated in Chikotay, and you could see already this particular one had a thyroid. This was 188 BC coin, which showed a thyroid mass. So people did recognize thyroid that early. This was also a very old picture of Judas goiter being treated. And this was a 785 AD bas relief, showed in Guatemala, showed quite a lot of thyroidal presentations, probably cretinism. Now, Indians in Gandhara depicted thyroid on the relief, in a stone relief, and you can see those demons affecting Gautam Buddha. They had goiters, and goiters reduces intelligence. The people become demonic, and that's what it is shown here. This side demons and these sides goddesses affecting the meditation of Gautam Buddha. This was 350 BC Sicilian crater where showed a hunchback active with goiter. I was interested in this because quite a few eminent thyroid surgeons were looking at the history and art, and they said the man looking at the history is very, very important, and he will aid in the progress of the surgery. That's what their idea was. And subsequently, this was a picture in 1622, a hunchback with walking stick supporting his goiter. And this is a photograph in Sumatra. This is exactly same, 1622 and 2006. Just the same. Humanity suffered from thyroid disease for a long time. And it is also depicted elsewhere in the tarot deck. These are all very, very important pictures of Renaissance arts. And prior to that, this is Megenberg's picture showing a large hanging goiter here. And this was Mantegna's very popular drawing, and there was a picture of thyroid incision and also the child having a cretinism picture of cretinism. And Leonardo da Vinci recognized thyroid in his art too. This is Michelangelo's picture art, and this is very, very popular art, and it shows evidence of this is a 16th century masterpiece actually, and you can see this gentleman having a very big goiter with the venous congestion all over his neck, and he is extending his head, probably giving rise to a phenomena where the venous congestion becomes common. And this was the maid had a large goiter. This was another picture from Naples, Italy. And you know all you know about Raffaello's pictures. His art always depicted some amount of thyroidal issues. This is a great picture of painting on Sistine Chapel, and you can see this audience had a large goiter here, and they are pointing at the goiter. This is Michelangelo's drawings as well, with the large goiter there. Cleopatra's relief had, she lived in 69 to 30 after Christ, and she had a large goiter according to this relief, as you see here. And also she had a very bad nose and a smaller breasts, and in any modern ENT surgical department, she would have a reduction rhinoplasty, total thyroidectomy, and augmentation mammoplasty. But still, she considered as one of the beautiful lady lived in that era. And subsequent pictures also suggest some of the thyroidal manifestations. And here you see this lady in the mirror having a thyroidal swelling. Now, all the important Renaissance artists have depicted ladies, beautiful ladies with some amount of thyroidal issues. That means in Renaissance era, mild thyroidal swelling was considered to be very sexy. And they thought the purpose of the large thyroid is to enhance the beauty in the neck. These are all depicted in this multiple sites. That's a bit of art and the goiter. When we come to the crux of the topic is how do we make decisions in thyroid, swelling and surgery, and also how do we safely carry out this procedure in a multidisciplinary way. The data I present, this one is obtained by 2 secondary care centers I work in. One is the Whangarei-based hospital, and one is the Northland District. This is the Manukau Surgical Center where I'm clinical director. And these 2 hospitals did not have cardiothoracic surgeons standby, so I had to make all the decision of which patient needs a cardiothoracic intervention, which patient doesn't. So that was a bit of a necessity for me and became a research topic. I had patients who are belong to indigenous population called Maoris, most of you guys know, and they had large goiters. And also the European population, which entered into this mediastinum very easily as a highway. They were going into mediastinum right, left, and center. So this is a lady, as you see here, she had a sternal wound and also the neck wound. This is her CT scan. I had to take her to the tertiary center to do the surgery with the cardiothoracic surgeon's intervention. That means I needed to decide when the sternotomy was needed, when the sternotomy was required. So that became a research topic for hundreds of thyroids with decision making for the surgery and the safe surgical pathway. So if you look at Dr. William Halstead's sentences, the extirpation of the thyroid gland for goiter typifies better than any operation the supreme triumph of the surgeon's art. This was also mentioned by Theodore Coca. If you're doing a thyroid, it's like meditation. It's like beautiful moments of anatomy, physiology, and working with endocrine glands. That's why I fell in love with thyroid surgery, and I thought, oh, this is the place I need to. Even though we were strongly trained in otology and rhinology in Davangere, head and neck was not that much exposed. However, those primary skills were useful in complicated thyroid surgery. So, surgical approach for thyroid surgery is controversial, as you see. It remains controversial. There is no evidence in the literature which patient should have a sternotomy. So the prevalence is 1 in 5,040 in general population. This study is Australian study, maybe more biased towards European population. However, we do see a lot of thyroids going into retrosternal area, almost 20% of them. When you look into how do we classify retrosternal goiter, there are hundreds of classification system. I apologize for this busy slide. However, there is no definitive definition for retrosternal goiter. What I use in my practice, or our practice in the department, is any thyroid gland going below the manubrium is considered as retrosternal goiter. We had CT criteria for retrosternal goiter, extension below the plane of thoracic inlet. This is a thoracic inlet here, at least 3 centimeter or 50% of the goiter staying below the thoracic inlet. So we thought, okay, let's get the CT features, which predicts whether the sternotomy required or not. Identify those patients who are more likely to require median sternotomy on the basis of CT findings, because most of them looked normal on the clinical side, but CT was horrendous. We had a retrospective analysis of these patients, 2009 to 2016 only. I have added 50 more cases since then, but this was the published report. That's why I'm presenting this data. Total in 2 centers, we did 559 cases of thyroid surgery, but 87 patients were retrosternal goiter with the CT criteria. So in that 87 patients, 6 patients needed cervicothoracic approach. That means medial sternotomy. When you look into that, it was evenly distributed everywhere, cervical approach and cervicothoracic approach, and there are p-values there. And as you see, there are a lot of presentation, and many were asymptomatic. This was very interesting, including my anesthetist who came with my migration X-ray of the chest, showed a tracheal deviation. Will you have a look at it? And that was large retrosternal goiter without any symptoms. So it can be very subtle to significant stridor. So it can be anything, actually. But majority of them had compressive symptoms like shortness of breath. This was my anesthetist X-ray CT scan. As you see here, 2 small thyroid in the neck and a huge component in the mediastinum. And very interesting X-ray. So when you're operating on colleagues, you need to be extremely careful. And this was his another patient's CT with the vascular involvement. And these are the patients who were showing evidence of Pemberton sign. Couple more. As you see here, this was a completely a mediastinal goiter with a little bit of connection to the lower end of the left thyroidal lobe, but majority of that was in the mediastinum. So the p-values became very important when they were aortic arch, relationship to the aortic arch and tracheal bifurcation. It became statistically significant, as you see. And rest of them were absolutely not significant at all, even though numbers were very small. I'm going back here, whether it is at aortic arch, above aortic arch, or inferior to aortic arch was the most important thing. And also tracheal bifurcation, which is next to the aortic arch. And also posterior mediastinal goiter. As you see here, the goiters usually go down in the anterior mediastinum, reaches the aortic arch, but some goiters can go into the posterior mediastinum. These were the dangerous ones. These were definitely needing a sternotomy. So in this study, only few studies we could see on this. 5 patients had a retrotracheal goiter, and this was around 50 cases. And this was our case series. We looked at the complications. Length of hospital stay was more compared to the cervical and cervicothoracic. Cervicothoracic approach obviously stayed in the hospital for more days than simple retrosternal goiter. And we never had a tracheomalacia. And always people ask me, have you ever seen tracheomalacia? Because I do most of the thyroidectomy in both centers. And I say, I never say never, because the next patient may have a tracheomalacia. So in medicine, never say never. So CT scan was useful, and it's absolutely necessary. And if it is beyond the level of the aortic arch and tracheal bifurcation, it increases the likelihood of requiring a sternotomy. So involve the cardiothoracic very early. If it is not reaching there, and if it is just a retrosternal, cervical incision approach alone is enough, as it is proved by most of our patients. Now, when you put a patient in prone, it's very interesting. We always take a CT on a supine position, but if you put in a prone position, usually the tracheal compression is not that bad. So that's another trick. Posterior mediastinal goiters always put the recurrent laryngeal nerve above the thyroid. So as soon as you open up, look at the strap muscles, you will see the recurrent laryngeal nerve. You need to be extremely careful about that. This was published in oris nassus larynx from our center. Now that is the second part. The third part was thyroid toolkit. What is the thyroid toolkit? This is very important for any unit which handles the thyroid surgery to have complete understanding of history of the thyroid problem and anatomy and surgical steps. We should be flexible enough to have all the surgical issues. Perioperative teamwork. This is very important, involving the anesthetist very early, and also getting appropriate investigations like fiber optic nasopharyngeal laryngoscopic documentation of the video and vocal cord findings, and also supraglottic edema. Biochemical investigations like parathyroid hormones, thyroid hormones, vitamin D and calcium, because most of us are vitamin D deficient. And if we supplement vitamin D much early prior to the surgery, the chance of hypocalcemia is much less. And having all the appropriate gear like intraoperative nerve monitoring, harmonic scalpel is very, very important, because they reduce the time of the surgery and also reduce intraoperative complications as well. And also knowing how to manage the complications. This is very important. To have a department and units policy on how we manage hypocalcemia, and also in the ward hematoma. We'll come to that in a minute. And also we should be open to lifelong learning. I think these are our very important thyroid toolkit. Retrosternal goiters may come in the neck, with a lot of signs, and also can extend into the chest. The neck may look absolutely normal in some of the patients, and all the neck swellings are not goiter. This was very interesting case, and this case was a large collection of fatty tissues in the neck, causing all the symptoms of thyroid. So having a cross-sectional imaging is very, very important. This is one of my patients. I took permission for publishing her photograph. This is a Maori lady. She came, her neck looked normal, but she had an enormous goiter up to here in the neck, in the chest. And when she put her hands up, she became really rosy, became quite congested in the face. This is called Pemberton sign. But what we teach here is Pemberton symptoms. She also felt breathless. She also felt dizzy. And her venous engorgement you cannot see because she has huge shoulders. However, that's all called Pemberton syndrome. So teaching should be not only recognizing Pemberton sign, which becomes a 1 second hands up and down, which is looking at Pemberton syndrome, which indirectly gives rise to your suspicion of a significant compression of the trachea and vessels. Now, this particular slide video, if you see, there is a large retrolaryngeal, retrosternal, retrotracheal, and cervical and mediastinal goiter. So I'll run this again, just focus on the goiter here, retropharyngeal, retrolaryngeal, cervical, and with deviation and compression, and also you could see how much the trachea is compressed. This is a usual case which we deal with. And if you look at the laryngoscopy, this patient had significant supraglottic edema. These are all edema caused by, and also you can see this, the bulge in the posterior pharyngeal wall causing upper airway edema. Now, this is after surgery, how the supraglottic edema disappears and all those things disappear. It's very satisfying surgery. It's very important to recognize that. So to have a good airway management is very important. It depends on local practice, personal preference, individual patient needs, and also the organizational factor, and also looking careful reflection, discussion with colleagues, Google clues from patient evaluation. This is all context sensitive airway management in this patient. However, teamwork is very important to have a successful thyroid surgery. Not only teamwork, to have all the equipment what you need. And if you ask anesthetists what kind of airway they are going to have or what kind of anesthesia techniques they are going to use, because we all, ENT surgeons are very good in communication with the anesthetists. We always communicate, they are our best friends and we are their best friends. So in thyroid surgery, they become best pals actually, because they need us. Because if you ask 20 anesthetists, how do they manage this case? There will be around different plans, plan A and plan B and extubation strategy. Everyone had different plans, as you see here. And everybody had a different extubation strategies. So everybody had plan B, different plan B. This is our routine Monday morning huddle where I asked the anesthetist, what's your plan A? And what's your plan B? What's your plan C? And there is no issues with asking them because it's all teamwork ultimately. And anesthetist needs surgeons' help in identifying the trachea, identifying the larynx, because they always look at the larynx from the top, but we always look at the larynx from in a different way. So we do look at the larynx 20 times a day. They look at the larynx just 20 times a day, but in a different way. So to have that here, as you see on the top, I'm trying to do a fiber optic awake intubation. This central one is one of the top anesthetists, and this is another colleague of mine looking at the screen. So having a successful intubation makes them really, really not de-stressed. It can be very difficult because the larynx anesthetist look is something different than what happens in thyroid surgery. And this patient's supraglottic edema was so severe, she needed a tracheostomy after the surgery. You can see here, she had significant supraglottic edema, and this did not relieve and caused a stridor, and had to do an emergency tracheostomy after the thyroid removal. And this was her trachea before, and you think, oh, there may be a tracheomalacia, but after the substernal goiter removal, the trachea regains its diameter. Now, it's very important to look at all the aspects of the thyroid surgery, especially recurrent laryngeal now. This is very pertinent in the thyroid surgery to identify, stimulate, make sure that you have a functioning recurrent laryngeal now before you go on to the other side. So when you do that, you need a real good training. In fact, you need to be very good with all the four approaches: medial approach, lateral approach, superior approach, and inferior approach. You may need any one of this or two of this in a case. So identifying Berry's ligaments, identifying avascular planes, identifying all your landmark in such a big thyroid becomes a little bit of issue, but we need to be extremely careful and conversant with the path of the recurrent laryngeal now. Now, other great stride in the thyroid surgery is harmonic scalpel. There is another thing called ligature. It is a bipolar, and harmonic scalpel is a radio frequency harmonic scalpel, which vibrates around 50,000 times per second, creates vibration of the tissue and coagulates it. I use this thing every surgery in a week, twice or thrice. This is very important tool for a safe thyroid surgery. Liga clips have revolutionized. I put a Liga clip and do this, and the registrars ask why you are doing two techniques on a vessel. I said harmonic scalpel is my preferred method, and Liga clip is an insurance so that I am not woken up in the night. So I put a Liga clip. It is shortened our operating time and a better operating field. This is a picture of a ligature. I don't have much experience with this. All my thyroids are being done with this. And not only the Americans, we also looked at how harmonic scalpel helps. Harmonic scalpel wins in everywhere, except in recurrent laryngeal now paralysis. You shouldn't be using anything very close to the recurrent laryngeal now anyway, but if you use it's really not good. And rest everything, it's quite good. It's less cost, length of stay is less, neck collection is less, drain output is really, really less, blood loss is definitely less, operation time is shortened, and hypoparathyroidism is also quite less. Now, sometimes we lose the signal while we are doing one side. It creates a lot of stress in the department, in the theater, but you need to have a troubleshooting algorithm pasted on in the theater wall so that you are quite good in managing that. If I lose the signal, I just make sure that I get the tube corrected, and I will open the carotid sheath and identify vagus nerve and stimulate that. And if it is really lost the signal, I don't go ahead. I just do half the thyroid and come back later. So that troubleshooting approach is very, very important. Some of the hypoparathyroidism chances after the total thyroidectomy. It's around 10% in our hand. I tell this to every patient, and we identify the risk factors, correct the vitamin D, and also monitor the patient afterwards with parathyroid hormone and serum calcium, and then treat if there is any issues. So for severe symptomatic post-operative hypocalcemia, we have calcium gluconate and oral calcium and calcitriol. We increase the dietary calcium intake and also address all the other one, because hypomagnesemia can present like that. And we discontinue the low-sec proton pump inhibitor because it inhibits the calcium absorption, and also trend electrolytes. Now, the newer emerging techniques are identifying the parathyroid gland in the bed and preventing harm, and also using recombinant PTH. These two are not available in New Zealand yet, but we are waiting for those. Now, post-operative hematoma, it's a really worrisome complication. Very recently, ENT UK and the British Association of Endocrine and Thyroid Surgeons have come out with hematoma following thyroid surgery management. It's a fantastic document. I really recommend all the postgraduates to read this document and also be very clear about how do you manage thyroid hematoma in the ward. There is a technique they have mentioned, it's called scoop, which is removing steady strips, subcuticular sutures, pushing the fingers in and open the skin to expose the strap muscles, opening the strap muscles to expose the trachea, and opening it up, putting a cover and taking them to theater. This saves life. This really saves life. And it happened in our own ward a couple of times. And this is already on the ward. We attached to the patient bed. And as you see here, those pictures I showed you, the large thyroid, when you remove large thyroid, you create large space, and it creates bleeding. Now, I would like to show a picture. Yesterday, I operated on this patient. I would like to share that with the permission of the chairperson. There's a lot of chitter chatter in the, sorry about the lot of chit chat. See, this was another one which I removed yesterday, a large retrosternal, retrolaryngeal, retropharyngeal approach. Very successful surgery because I have included our the team approach. This was the case. This was done yesterday. This is the lady, as you see here. She's the local, and she's around 20 centimeter incision here. And this is a main anesthetist and a secondary anesthetist, all the equipments and anesthetic tech, and the nurse looking upon. And I'm taking the photograph here is because I am by the side of the anesthetist for this. They all get to really a good cooperative team when you show a lot of support to them, being there rather than in a coffee room. Tea room is next door. We are not in tea room. We are here with you. So thyroid surgery is really great. If somebody wants a thyroid surgery, I'm happy to have a Zoom talk with them and go from there step by step, very safe, and it's very enjoyable. However, there are a lot of sharks in that thyroid surgery, and we may be directly landing into troubled waters if you don't have a good teamwork and good understanding. So basically understanding thyroid from its physiology, anatomy part, and then going ahead with the surgical training and then a collaborative teamwork. I think the teamwork is the most important thing in the thyroid surgery. It is not one-man sport. It is a team sport. So with that, I would like to end my talk. Thank you.
Thank you, Dr. Subhash Chandra Shetty. It was a wonderful talk, and we really appreciated your experience with large retrosternal goiters and the pearls of wisdom which you gained. But as well, and I think the audience has lots of questions, but they cannot ask as per the protocol of the oration. I think they'll be contacting you. Over
Yes.
to Dr. Karnataka.
So, thank you, Subhash Chandra Shetty. It was a very useful and informative talk. So nowadays, more and more ENT surgeons are moving towards thyroid surgery, which till now many people thought that surgeons, general surgeons domain. So in this regard, you have stimulated a lot of youngsters to choose thyroid as a career. Thank you. On behalf of the organizers and the AOIK, I sincerely thank you.
I really thank Prof. Shivkumar, who is my mentor, for asking me to talk about this. I really appreciate his enthusiasm. Thank you.
We thank the moderators and the presenter. Thank you, sir. Thank you, ma'am. Our next session will be the 18th AOI Karnataka oration of the topic Stridor in Children, Recognition and Management.
We would like to call upon Dr. Dhanpal sir, Associate Professor, and he earned his Fellowship of Otology from France and has more than 10 original publications in reputed journals.
And Dr. C.V. Srinivas, sir, MBBS from BMC, MSENT from KIMS, and Fellow in Otology from Paris. He is AOI Bangalore President and AOI South Zone Secretary General and Editor of Karnataka State ENT Journal, among his various titles and posts he holds and held in the past. We welcome you, sirs, to helm this session as chairpersons and also to introduce us to the speaker for the session.
Unmute.
This state conference for managing the situation as per the existing conditions. And today we are all here to have a nice time of academic activities. As we move on to the next session for the day, the topic being Stridor in Children, its recognition and management. And we have a very good morning to Dr. Dylan Shetty, whom I have the pleasure of introducing today on this occasion. Dr. Dylan Chetty completed his MBBS from JSS Medical College, Mysore in the year 1996. He did his MS ENT from JJM Davangere in 2002. Did not stop there, went on to finish his MRCS surgery from Glasgow 2009 and did his diploma in head and neck surgery from London 2017. And for all his meritorious work, he was awarded the FRCS from London in 2020, and we are all proud of Dr. Dylan Chetty for his achievements. Further to which he went on to become a senior resident in neurosurgery from 2002 to 2003, was lecturer come assistant professor in Department of ENT at Manipal Teaching Hospital, Nepal, 2003 to 2005. A specialist ENT surgeon in the Ministry of Health, UAE, from 2006 to 2011. Was a senior clinical fellow in ENT at Royal Bolton Hospitals, NHS Trust, 2011 to 2013. Associate specialist in ENT at Royal Bolton Hospitals from 2013 till date. Is continuing his wonderful work there. He was selected by the Royal College of Surgeons of England as Senior Fellow in Pediatric Otolaryngology at Alderhay Children's Hospital, Liverpool, UK, for the year 2021 and the ensuing year 2022. His career interests are pediatric otolaryngology, benign head and neck surgery, simulation training in otolaryngology, and he is teaching the 4th year medical students in simulation. If I continue, I think it'll take most of the oration time. So I would stop here by telling that he is a tracheostomy safety trainer, the interview panelist for SAS doctors, representatives, and etc., etc., etc. Dr. Dylan, pleasure. Give me an immense pleasure reading your bio. Over to you now.
Thank you.
Welcome, Dr. Dylan Chetty. Yeah, you can start your talk.
Hello. Yeah, I'll start sharing my screen. Just a moment. Can everybody see me? See my screen? Hello? Yeah. Can you all see me on the screen? Just started sharing.
Sir, you are absolutely audible, sir. You can go ahead.
Yeah. So good morning, all. I woken up very early today, this morning, with a lot of excitement and nostalgia, in the sense that I'll be speaking to my training center where I started my initial career in ENT. Just a bit anxious and nervous also because I have all my teachers in the audience. So, well, my name is Dylan Chetty, as introduced, and I'm currently a clinical fellow in pediatric otolaryngology. Basically, we have only fellowship by the Royal College of Surgeons of England, and I've been fortunate for the last 6 months and continuing with as a senior clinical fellow. This involves a lot of work and also experience. First of all, I express my gratitude to my educational supervisor at the moment, who is Mr. Ravi Sharma, who is an airway surgeon in the institute. So we have a major tertiary hospital in Liverpool, which in fact is one of the largest, Europe's biggest and busiest hospitals in Europe. So we deal about nearly 500,000 of children annually, and the number is going up with a lot of referrals. In terms of ENT, we have multidisciplinary teams, including ENT, respiratory, long-term ventilation, and speech and language therapy, apart from allied specialties like neurosurgery and also respiratory medicine. The reason why I choose this topic in particular is when I started my MS training in Davangere, we used to get a lot of pediatric airway emergencies, primarily related to foreign bodies. And I went on to do my thesis in airway foreign bodies, aerodigestive tract foreign bodies. Some of you will find my thesis in the library. And I had the privilege of accompanying my consultants, my bosses, for nearly 200 bronchoscopies over a period of 3 years, and did a lot of publications. That was not the end of it. I am not sure where the rest of the airway patients used to land up with. So that at the back of mind, wherever I went, I took particular interest in pediatric airway. I worked in 4 countries and had the opportunity to deal with airway emergencies wherever I went, be it Nepal, be it Canada, be it in the UK or in the Middle East. So that drew an interest, and after working for 10 years in exclusively dealing with the pediatric ENT disorders, I landed up with a fellowship, being invited by the Royal College, not really selected, to specialize in pediatrics. Without going much into the nostalgia, let me go straight to the point. I'm going to split my talk in terms of 2 stages. One is what I'm going to speak to the audience, the aims and objectives, and also in the next PowerPoint, I'm going to share my own personal experiences with the current job and probably in the past, some of it. I'm very conscious that there are a lot of postgraduates, apart from seniors, who will be already doing the work which I have been doing, but I've focused mainly, as per our organizers, into dealing with the airway when it comes to airway anatomy, physiology, the spectrum of airway disease and its management options, and the pattern recognition, which is the key here. The question is, how bad is the airway, and how to safeguard the pediatric airway, and some of the interesting illustrations. The first thing is, when you come across a child with an airway issue, very often, majority of our chunk work in a district general hospital. I work in Bolton, which is a busy district general hospital, before getting into this fellowship. When you get a child and an adult side by side in the A&E, the assumption is that an adult is similar to a child larynx. That's the assumption, or the other way around. But if you proceed with that assumption, you'll end up in trouble. It's not a miniature airway in a child as compared to an adult. Getting into comparison, you end up here. Just a moment, just setting my slides right. This is where I end up with. A child's airway is at a risk of mucosal swelling and respiratory failure. Why does this happen? A lot of changes. The trunk can be larger relative to the oral cavity, which we obviously see. It's of small caliber, a higher praised larynx, C4 in comparison to C6 vertebra. Larynx is more anterior. Larynx is the narrowest point in an adult, but in a child it's subglottis. They all have prominent occiput, making positioning more difficult, be it to the ENT while doing an upper airway endoscopy, or to the anesthetist who is trying to intubate. Also, many of you will realize that the thyroid notch is hooded under the epiglottis in a child, and the cricothyroid notch is small. This brings to the point that if you are attempting a cricothyroidotomy, it's very difficult. If you look into the graphic structure and the alignment of the larynx in a child compared to the adult airway is tubular. However, in a child, it's conical. Also, you can see from the diagrams that in an adult, the glottis is mainly made up of the vocal cords. The vocal process is smaller proportionately as compared to the child. So there is more risk of injury to the cricoarytenoid joint. So I'm just preparing a stage where how different anatomically a child's airway can be. Coming to the physiology in brief, it's a totally different ballgame for both the ENT surgeon and the anesthetist. An infant can need up to 600 liters of oxygen per kilogram per day. So if you enter into a PICU, pediatric intensive care unit, you will be inhaling a lot of oxygen and gases and a lot of noises. And that's the reason they will be inhaling a lot of oxygen. And this was the main concern during the COVID in all of our PICUs, that what if a child, if there is an outbreak in a school or in a nursery care, if children come with a lot of increasing oxygen needs, we have to give them a lot of oxygen. Proportionately, as the child grows, a 6-year-old will need 400 liters and a 24-year-old will need 200 liters per kilogram per day. Interestingly, the total lung capacity, the dead space volume, and the tidal volume per kilogram body weight is similar to the adult. So if you look into the proportionality, there is increased metabolic rate, increased oxygen consumption, increased minute ventilation, small lung volumes, and ultimately a risk of rapid decompensation. So the end point is, if you end up with a pediatric cardiac arrest, always think of a respiratory cause. And it's not the end organ, the lungs or the alveoli very often, except in prematurity, it's mainly the airway that's the contributing factor. Coming to the physics, I'm not here to teach physics to everybody. Sometimes it can be really boring. But at the background of when you're dealing with an acute airway infection, keep in mind of Hagen-Poiseuille's law, Bernoulli's effect, and a number. So you have a law, you have an effect, and a number. If you carefully observe this graph, which you might find it in a lot of internet websites and journals and whoever publishes, somebody has wisely mentioned airway diameter against airway resistance to explain Poiseuille's law. The graph is self-explanatory. It shows how resilient and how fragile a pediatric airway can be. The law states that the resistance to flow through an airway is inversely proportional to the 4th power of the radius. As you go along the x-axis, the airway diameter gradually reduces to a stage of 75%, and everything will be nice and rosy. The child will be smiling, parents are happy, the monitors will not be bleeping, and suddenly the commotion starts in the resuscitation unit. So up to 75% looks all fine, but you have a narrow margin from mild, moderate, and near-death events. Interestingly, you are not called till it reaches a stage of moderation or near death, and that's where please call ENT, we have lost the airway. Interestingly, if you instruct or if you act at that stage, the reverse order is also true. If you start your temporizing measures, you can see significant improvement in the airway. This slide is self-explanatory. I informed that subglottic airway is the narrowest part. It's about 4 millimeters in a child, in an infant, and it's about 1.2 to 1.4 millimeters in an adult. If you narrow it by 1 millimeter, then the airway cross-section reduces by 75% compared to just 30% in an adult. That explains the graph and also the resistance. From 16-fold in a child compared to 2 folds in an adult. The effect. This is the effect that keeps the aeroplanes flying, that flies the roof off in tornadoes, and many more things. If you're driving a car on a busy road and you just go through the puddle of water, and if you're not careful, you just have an aqua effect. All these are explained by Bernoulli's effect, which states that if there is increased airflow velocity, there is negative pressure on the walls of the airway, leading to inward collapse. And this can happen at multiple levels. Say, for example, if you have a bilateral vocal cord palsy, you scope a child with all the commotion going on, you will think that there is supraglottic collapse, come to a conclusion that it is a laryngomalacia. So just have to be very careful. You have something called as Reynolds number. A bit complex to understand this. Reynolds is an engineer in Manchester. He came with this observation about what laminar flow and turbulent flow, which we always talk about in nasal airways and also in transmission of air through hollow structures. There is a point of transition between a laminar and a turbulent flow, and they give it a number for different media of conduction. So that has a factor doing with density, viscosity, and velocity of the fluid, the diameter of the pipe. Normally, if somebody asks you, what is the transition number? It's 2000. Anything beyond 2000 for around 2000 rather, not a specific number. If it transits beyond 2000, then the transition is from laminar flow to the turbulent flow. That's not all it. Level of obstruction. Scott Brown, many ENT textbooks will tell you, okay, fine, you have a fixed airway, you have at the site of the airway obstruction, the extent of the airway, supraglottis, glottis, and infraglottis. Yes. Not very often you get a fixed airway obstruction. Particularly in children, there are so many confounding risk factors which you need to take into consideration. So don't stick into the rule that an inspiratory or a biphasic or an expiratory stridor is suggestive of, but it's not definitive. There could be multiple level of obstruction. From my experience, just from last week, an intubated child with a complex cardiac issues had difficult extubation. You scope the child, you extubate the child in the theater. What do you see? You see a vocal cord granuloma because child is intubated for quite some time. You can also expect some subglottic stenosis. Don't give up at this stage. You need to have a full airway assessment because even after extubation, even after taking out these vocal cord granulomas, assessing the vocal cord movements, you didn't find the child any better. Going lower down, this is what I saw. This child has laryngomalacia, tracheomalacia, and compression from a vascular cause. So multi-level obstruction is more frequently seen in children. Sorry for this busy slide, but it's important to keep at the back of your mind about various causes for acute airway obstruction. Inhaled foreign bodies, I don't have to talk much about it because all of you see it on a day-to-day practice. And if you ask my teachers in Davangere, they will tell you stories and volumes. But what is important for you as ENT when called for a suspected foreign body, particularly in patients who come with recurrent croup. This was a patient, I put up 3 slides on the right just for illustration. This was a 7-year-old chap, unusual to have croup. He had 7 A&E attendances over 2 months, turned back from the pediatrics A&E, saying that it's a croup with some steroids, sometimes antibiotics, sometimes symptomatic medications. Interestingly, of all the visits, I happened to come across this patient twice within that short period of time. Something is not right. They didn't even bother an X-ray. Straight away taken to the theater, very likely suspicion of foreign body, and this is what we found. Deep neck infections, not so common in our settings, but I've seen it quite a lot in other countries, particularly in Nepal, where you get retropharyngeal abscesses. They come with acute airway obstruction, particularly in children. Supraglottitis or epiglottitis, whatever you would like to call it as. Vaccination was introduced in 1992 in England. So H influenza as a cause is very rare here, but you still see it in other countries. However, if we get a supraglottitis, very common, it's because of strep and staphylococcal infections in immunocompromised patients, and particularly in adult patients. Recurrent respiratory papillomatosis is quite common in this country of all age groups for different reasons. Don't forget the subglottic cysts. Acquired subglottic stenosis is rare because of the improved techniques of intubation. Occasionally, you might find a bilateral vocal cord palsy called from the neonatal unit. My focus would be more towards congenital, laryngomalacia being the commonest cause for stridor, congenital cause for stridor in neonates and children. We do get occasional subglottic stenosis. Vascular rings are very common. Hemangiomas, very interesting. We do get it very often. Clefts, webs, atresias, these are all routine happenings in any pediatric unit. We have lots of patients waiting to have definitive treatment now, and because of the COVID, they are all delayed. Don't forget the dysmorphic features in a child, a large tongue, a micropratnia. You can end up with trouble when you try to intubate. And also, it's important to look for other causes like systemic causes. In fact, my first tracheostomy in this country was on a patient with angioedema, where everybody lost the airway. If you are in a higher center, you might be called for tumor compressions, as Subhash said, extrinsic compression. Very commonly, a teratoma, a schwannoma, and a lymphoma. When it comes to diagnosis, coming to the topic proper, try to ascertain the site and cause of obstruction. Very often you may not be able to. What is the effect on the airway? And also not just the airway. Be conscious about the feeding, sleep, exercise, and growth of a child. If you're looking at a child in the clinic with intermittent stridor. The important bit to understand here is children have this pattern of suck, swallowing, and breathing. So if any of the component or the chain is broken, they end up with problems relating to all three. You all would have read this. Always listen to the mother or the carer. They will tell you stories. They live with the child. You might be seeing it for just 15-20 minutes of the child for assessment. They might tell you the real pattern when it really happens. Look into the perinatal history, prematurity, ventilation, intubation. We all know that, we all ask it, but still don't ignore it. Was it a difficult delivery? Age at onset, whether it happened immediately at birth, very likely suggesting an fixed obstruction. Weeks to months, underlying laryngomalacia most likely. Extra or intraluminal, that comes later when you try to investigate. A lot of confusion regarding terminologies. When you are called, ENT is called, you are given a mixed up terminologies. Many people can't really say whether it's a stridor, stritter, or a wheeze. Even any consultants have called me saying that the patient is stridorless. You go there, this patient is having a wheeze. However, for the exam point of view, if you are confronted by a cheeky examiner, stritter, low-pitched snore, start with the low-pitched snore. Stridor, high-pitched musical. Realize that to have a stridor, you should have partial obstruction. If it is complete obstruction, though temporary, it's apnea. Ask for always the pattern. crying, feeding, excitement? Is it worse on when the child is asleep? We all do this, the ABCD of resuscitation. One of my cases recently, just called by the cardiac ITU, Silas attended with respiratory distress. You just see the skin lesion there. We have been called with a suspicion that the child could be having a hemangioma. And true to my suspicion, we come across this. This is a teaching video. Can everybody hear the audio? Can clearly observe the child in distress. You can see the child in air hunger. You can see the tracheal drug, subcostal recession, use of muscles of respiration, accessory muscles. They have a low density of type 1 muscles, so they don't use their intercostal muscles so frequently. It's mainly diaphragmatic. When it comes to symptom correlation, a lot of textbooks tell you different patterns. But don't forget the neurological status of the child. No matter however you correct the structural abnormality, if the child is syndromal, if it is hypertonic, you can't really assure complete recovery. This child will need further respiratory support. One of the roadmap is to look into the red book in this country about the weight gain. Children drain away a lot of calories working hard to breathe through an obstructed airway, and they will lag behind in the growth chart. On the background, keep in mind any cardiothoracic surgeries and the skin lesions which I showed you. Some of the things I marked in red and green, ask for audiovisual recordings from the parents. Everybody will have a smartphone nowadays. Type of stridor is not always diagnostic. And mind you, cyanosis is a late event. Always don't forget to assess the nasal patency. If you do suspect epiglottitis, you know what to do. Don't annoy the child. Stay away. The potential for complete airway obstruction, inform the anesthetist. And if the airway is unstable, everything needs to be done in a theater setting. So just a chronology. Situational awareness is very important. It's an acute situation. Please realize that. It needs careful planning. Everything happens synchronously. Temporizing measures, assessment of the child by the pediatric physicians and by the ENT on site. Always contact the theaters for an impeding airway obstruction. Remember, you have a functional airway, but it's a compromised airway. These are given in all textbooks. We all do that. But important to start temporizing measures as soon as possible. Nebulized adrenaline, the good part is that it doesn't have much side effects. It can be repeated, except the patient has a complex cardiac problem. Dexamethasone will take a bit of time to start working, but it is about 50 times more potent than hydrocortisone. Even if you can't get a cannula, start oral dexamethasone. In some centers, we do give budesonide, but it's a bit expensive, so they don't encourage it. The next step would be for an airway assessment. Go ahead with flexible nasal laryngoscopy, provided it is safer to do so. In a child or an infant, it is easier said than done. And it's easier to do, but difficult to interpret. This has its own limitations, particularly if you're suspecting a supraglottitis. Don't try to do it in the A&E settings, do it in the theater. It's easier to do a nasal endoscopy in child with less than 18 months and above 4 years. In between, we will all kick off. Airway assessment begins from the nose, as I've said. From my personal experience, only recently, there was a child born in the women's hospital with neonatal distress. Nobody knew what's happening. They were able to pass a French size catheter 6 through the nose, but the child was desaturating. Very quickly, the neonatologist, pediatrics, joined together and intubated the child and sent the child to our PICU. You do attempt a nasal endoscopy, what do you see? You can clearly see that this child has piriform aperture stenosis. Normally, we do have a piriform aperture sized about 1.2 centimeters, 1.3 centimeters. This child has a piriform aperture of 0.47 centimeters. The child being an obligate nasal breather, completely desaturated, and ended up with endotracheal intubation. Also, you can see that as a part of the syndrome, this child has central mega incisor. We have ended up doing serial dilatation of the left nasal cavity, and I'm training the parents to help the child to grow up with a nasopharyngeal airway. The gold standard for assessing an airway is a microlaryngotracheal bronchoscopy. It has various terminologies: laryngotracheal bronchoscopy, upper airway assessment. So every institute has its own nomenclature. Or there are various indications where we do MLTBs. You can read all of that. I'm not going to bore with this busy slide, but what is important for you, having encountered an airway emergency, you need to make sure that your equipment is in place. No matter how often you do an upper airway endoscopy, find time to keep checking the equipment is functional and appropriate and in place, and you get it where you want to use it. Because the last you want at the end of the day, as it happens very often, is being called by the anesthetist to establish a definite airway. And you don't want to cut a child's neck to do a trachea or a cricothyroidotomy. There are various adjuncts. If you look into the difficult airway chart, if ENT is available, you're always called. This happens in mainly tertiary care hospital. However, if it is in primary care, healthcare center, and also even in a district general hospital, the ENT may not be available for the next 30 to 45 minutes. However, if you enter the circle or a cycle at this stage, be ready with the rigid bronchoscope with a size appropriate endotracheal tube mounted on your Hopkins rod telescope. If you start your job as a pediatric ENT, know where your emergency airway trolley is kept. And very often, more than the therapeutic role for an MLTB, majority of your airway work would be diagnostic. We do a lot of MLTBs, but that doesn't change the immediate management. We did a study over last 10 years in Aldray, and very commonly, we found significant changes in just 33%. and that doesn't change the immediate management. So work is underway whether routine MLTBs, particularly for recurrent group, should be advocated. I would be keen to know the thoughts of people practicing pediatric ENT about their experiences with MLTB, particularly for patients referred with recurrent stridor. So it comes back in circles. Proper history. History is the key. Sometimes you may not be having the time. You'll have to establish the airway. Examination, nasoendoscopy, MLTB, and further investigations. Always, what is important, like any airway exercise, is situational awareness. I've kept this slide empty because if you don't know what you're doing in an acute airway emergency, stop, take a deep breath, and think. Always have a plan A, plan B, and plan C, just like your thyroid airway surgeries. This is very interesting. You can see this. I have put this child with a purpose, with escalation thresholds. If you enter a Chakravyuha, some of you who might have read Mahabharata, you get into Chakravyuha, you need to know how to get out of it. You should have a plan. So that's the first part of my talk. I'll show you some illustrations and we'll be quick now. So I'm just swapping my slides. Okay. Venkatesh, are you there? Can you see the slides clearly? Venkatesh?
Yeah, seen.
Yeah.
Seen very well.
Yeah, so it's a very quick overview of what we can expect from a microlaryngeal bronchoscopy. So the first on the left-hand side, you have a Lindon suspension microlaryngoscope. You visualize the upper airway. So far you can see it with the flexible nasolaryngoscope. What goes below needs to be ascertained. So the patient is on a spontaneous breathing circuit. Intravenous anesthetic with inhalation. So you go through the trachea, a systematic approach, document everything. If you are doing an MLTB, nice and clear. You can see the tracheal rings very clearly. So just be observant of what's going on around you in the theater, not just the airway. Situational awareness is very important. What you can see here, something interesting. You see the carina, you can see the right and left main bronchus. You might be into surprises, though essentially this airway is normal. You can see a pig bronchus. This is very common in pigs. So the one of the main bronchus has come from straight from the trachea. Going to the next, a commonest reason for a congenital pediatric stridor. This child has severe laryngomalacia, a floppy larynx being sucked in. You can see the edematous arytenoids, a lot of soft tissue collapse. And what do you do next? You do epiglotoplasty being done here. You release the aryepiglottic fold on both sides. A very simple procedure can make a massive difference, though not always. I put this laryngomalacia specifically because 75% of the cases of stridor in children, in infants and children, are due to laryngomalacia. Normally, if you look into the aryepiglottic fold and glottic ratio, it should be 0.54. However, if it is less than 0.34, in theory, that can cause significant symptoms. Nobody knows why it happens, whether it is gastroesophageal reflux, which could be cause or an effect, or a neurological immaturity. There is some theory regarding overgrowth of third arch cartilage, which is the epiglottis itself, or poor calcium deposition. There's not much evidence for it. Mind you, this is a dynamic obstruction. Child will come with feeding difficulties also. There's about 20% failure rate, and only 10% need surgical intervention. Situations where you dive into doing a supraglottoplasty or an epiglottoplasty is when there is failure to thrive, and the child is having recurring apneic episodes or ending up with serious complications, particularly pulmonary hypertension, severe dysphagia, pectus deformity, and carpal nail. Interestingly, you don't stop there just by snipping off the aryepiglottic folds. You do a concomitant MLTP because the chances of finding a second airway abnormality is about 20%. Very commonly, you might find a subglottic stenosis or an underlying trichomalacia. Be very careful when you make a decision for an aryepiglotoplasty, particularly in patients with neurodisability. If you find a retrodisplaced epiglottis, this is highly suggestive of an underlying neurological cause. So stop. If there are a lot of secretions, if there are cervical spine abnormalities, if you have some signs of peripheral neuropathy, particularly from brainstem compression, or if the stridor is a new onset beyond 6 months of age, yes, be careful. You may not be having anticipated success in these procedures. Have a look of it, one of my patients, an infantile epiglottis, very clearly seen, and you're snipping it off. For the sake of time, I'm just cutting this video short. So that's the aryepiglotoplasty. You can also do something called as supraglottoplasty. All the redundant mucosa on the arytenoids can be debrided or excised. You can also do epiglottopexy, where you can use various techniques to antepose the epiglottis anteriorly. And this is how the larynx behaves from the previous video, what you saw. So the collapse is minimal here. So this is a very rewarding procedure in rightly selected patients. Some of the interesting findings from my personal experiences. Look into this. You're doing an MLTB in a patient who is come with the increased work of breathing. Start guessing. I'll stop here. You're looking into the tracheal rings. There is a single complete tracheal ring. Not all tracheal rings, complete tracheal rings need surgery. Quite a significant narrowing at one level here. Going to the next, a similar patient. Sorry, I'm trying to fast forward, but I don't have this option. There are multiple tracheal rings and narrowing out there. So be ready for any sort of surprise. Foreign bodies, we get a lot of this. One of this patient last week had to be air evacuated. Commonly less than 3 years. You know the reason why it happens. History may not be confirmatory. No radiological evidence might be confirmatory. It's your gut feeling. Very often in less than 3 years, it's not an observed event. So you resort for an upper airway endoscopy. So this is what we say, a pencil top, nicely lodged in the right main bronchus, also obstructing the left airway. I'm not going to talk too much because there are experts in the in the audience. We'll ask any of the ENT in Davangere, where I mastered my skills of removing these foreign bodies. You do get supraglottitis very rarely. Be aware that you might have to intubate this type of children. Vascular rings. Very often you will be troubled in the middle of the night with a stridulous child with a complex cardiac problems. So this was one of my recent MLTVs. That's a beautiful slide which I put up from Hollinger about various sites where you can expect. Keep an eye on the second pathologies also. Okay. So you can see the tracheomalacia with a comma-shaped sort of trachea with significant pulsations. So if this child, if it becomes stridulous, don't venture straight away doing a tracheostomy. So when you start with the scope, you can see that there is some cobblestoning posteriorly. And also, if you have noticed, there was a small laryngeal cleft also. So be very mindful. You can see the laryngeal cleft there, grade 1. That's the area. Okay, and then there was cobblestoning. Iotopexy in properly selected patients where works very well. You can see the same patient who had an iotopexy breathing normally now in spite of the pulsations. Papillomas very common. Our policy is to debride them. Of course, more than 4 debridements need cidofovir. We need special approval for monoclonal antibody treatment. That's one of my senior colleagues who is a master in this technique. And then every so often, you do end up with scoping a patient for subglottic cyst, very common subglottic cyst, because patients who have been intubated and then they end up with difficult extubation. You go in, you find a lot of subglottic cysts, you marsupialize them, but still they become stridulous. So don't forget to scope them within 6 weeks because there is a very high risk of recurrence in these patients. This is one of the acute airway emergencies. Papillomas are really common in this country. This child came with a completely obstructed airway. All I had to do is push an endotracheal tube with a Miller blade visualization. This child's mom says that 18-month-old child says that she never heard a proper cry or a proper word from the child since birth, and finally came with acute airway obstruction. So still you can find papillomas in this country. And that's when we evacuated, and then they thanked me not for saving the child's life. They thanked me because the child would start making noises. This was one of my recent complex cardiac patients. We find that's the laryngeal spreader. It's a wide laryngeal cleft, grade 3. You follow it down. You can see the cleft extending right up to the lower border of the trachea. This will need an external approach, but this child has complex airway issues that needs to be sorted. So these are some of the illustrations. And with this, I end my talk. Happily to invite you for an upcoming Congress, probably in, COVID allowing, in 2023, hosted by my department. You are more than welcome to visit and attend this conference. If you're all interested, you can really get in touch with me and be our guest. Thank you very much.
Thank you, Dr.
You're very welcome.
Thank you, Dr. Dilin Shetty. It was a wonderful talk on management of pediatric airway. And any questions from the audience? No questions. Thank you so much.
You're
Thank
very
you,
welcome.
Dr. Dillon. Thank you very much. It was a pleasure listening to you. A lot of take-home messages. Thank you so much.
Thank you.
Thank you, sir. We would like to call upon Dr. Yogesh sir and Dr. Venkatesh sir to present the mementos to the moderators. Sirs, please.
Tea has been made available for anyone who wants to see. Snacks are also available.
We'll be continuing with our next session. Our third session for the day will be Dr. Suryanarayana Rao oration on the topic game-changing role of MRI in management of mucormycosis. We would like to invite Dr. Virendra Gausis sir, who will be joining us online. He is part of the Gausis ENT hospital in Pune. He did his PG from JNMC Belgaum and is a renowned rhinoplasty surgeon.
Would also like to call Dr. Kailash Pujari sir, professor and head of Department of Otolaryngology, Kasturba Medical College, Mahe, Manipal. Kindly chair this section for us, sir, and introduce us to the speaker of this session.
No. Yes.
Yes, sir.
Third one.
Third one was not.
ಅದು ಹಾಕಿಲ್ಲ ನೀವು.
First ಶೇರ್ ಮಾಡಲ್ಲ ಸರ್ ಇದಕ್ಕೆ
ಸೂರ್ಯನಾರಾಯಣ. This one.
Hello. Yeah, I'm Dr. Hesas here.
ಶೇರ್ ಮಾಡ್ತೀರಾ? ಶೇರ್ ಅಂತ ಕ್ಲಿಕ್ ಮಾಡಿ. ಶೇರ್ ಅಂತ ಕ್ಲಿಕ್ ಮಾಡಿ.
Satish Jain.
Hello. Hello, am I audible to you? Hello, I'm Dr. Virendra Hesas. Am I audible to you? Hello, I'm Dr. Ghaisas. Am I audible to you?
Good morning. We'll be starting the next oration, which is the Dr. H.V. Suranarayan Rao oration. Dr. H.V. Suranarayan Rao was born in 1912. He's a ENT surgeon who's known to most of the surgeons in ENT surgeons in Karnataka. After qualifying as a ENT surgeon from England, he chose to settle at Mysore and to become one of the most illustrious surgeons of that era. He was a founder member of the AOI Karnataka chapter. He was the head of the Department of ENT at Mysore Medical College in Mysore. He also headed the Department of Dental Surgery, where he carried out different types of dental extractions and also dental surgeries as and when required. He later on progressed to become the Vice Dean of MMMC, and even after retirement, he was actively associated with Holdsworth Memorial Hospital. This is about the illustrious surgeon, ENT surgeon, Dr. H.V. Suran Rao. I request Dr. Gisais to introduce the speaker, Dr. Satish Jain.
Yeah. Hello, am I audible to you?
Voice is not there.
Hello, am I audible to you? Hello? Hello, am I audible to you? Hello? Hello? Hello, am I audible to you?
You're not audible.
Hello?
Hello.
Yes, am I audible to you?
Yes, Virendra. Yes.
Hello. Yeah. It's on behalf of Dr. Deepak Haldipur, because he's operating right now. I'm Dr. Virendra Ghaisas. It's my great pleasure to introduce Dr. Satish Jain. Now, everybody knows about Dr. Satish Jain. I'll tell you one story, like why Satish Jain is Satish Jain, the Satish Jain. Because he still feels that he is a student. You show him some new article, he will dig it out, he will read it, he will go to his radiologist at 2 a.m. and he will do entire research. Now, the biggest introduction to Satish is he's a voracious reader. He's a great surgeon and with a great surgical skill that everybody
Sir, your
knows
mic
about.
is mute, sir. Can you unmute and try once?
Dr. Gisais, we unmuted from this side.
From this side, okay. Is it audible now? Is it audible now? Hello?
Wait, my team is there. I'll call you.
Am I audible now? No.
Hello. Hello.
Yes, Virendra, you are audible.
Yeah, okay. So I'll start. Yeah, Satish, it's my great pleasure to introduce Dr. Satish Jain.
Come on, come
For-
on. My introduction is I am student of Virendra Gaisas.
No. That's that's introduction.
That
Satish
gives
is
me
a
highest
great
pleasure.
student. It's a great student, and he still learns. He's a voracious, I will say eater of that knowledge, and he will still you show him something new, and then he will still like to read the new topic, and he will read all the subject, the new technique. That's the best introduction of Satish Jain. Apart from his massive surgeries, more than 7,000, and what not, maybe 70,000. The main introduction of Satish is he's a great student still, and he still goes to the radiologist. I have personally seen going him at 2 a.m. in the morning with the sitting with the radiologist and discussing on the films. I think that's his best introduction. And apart from that, he's a great human being, because only a good doctor does not matter. A good human being along with that is what matters for a patient's care. So, and he's my dear friend, and I won't come in between you and Satish. Satish, we are eager to watch your oration, to hear about you, your pearls of wisdom. Please carry on, Satish.
Thank you, Virendra. Thank you
Thank
for the nice words, and it's always a pleasure being with you to learn from you, and will not leave you so early. We have to learn more and more from you every time we get opportunity. Thank you once again.
Thanks,
And,
Satish.
and
Please carry on.
it's really a privilege and honor for me to deliver this prestigious oration, and I'm indebted to the organizing team, especially Dr. Gangadhar, who is the president for the AOI Karnataka and AOI Davangere team as well. I am indebted to Dr. Sridhara, who is secretary, Dr. Basivraj, and Dr. M. Srinivasan, Shiv Kumar. I am really grateful to everybody for giving me this opportunity to share my small experience with you all there. Thank you once again. Coming to the next 45 minutes with this topic, we all know after the COVID, the thing which hit badly to this mankind was a dreaded disease we all know, unforgettable mucormycosis, which is an, I would say, invasive fungus which give acute fatal invasive fungal sinusitis. And this came all of a sudden in big numbers, and took a big toll. A lot of people died because of this disease. There were a lot of challenges during this course of mucormycosis pandemic, and the biggest was the early diagnosis. We all know, for like any disease, the earlier you diagnose at the early phase, better is the chance of the treatment. And the challenge was in the mucormycosis was the presentation, which was the symptomatology, which was not very specific, but was related to, not related to the paranasal sinuses or everything. Every time it was vague, and the diagnosis was mainly based on the radiology to pick up early this lesion. And there comes the role of MRI, which I'm going to talk for a couple of minutes, that how it could change the game to pick up the early and cure those patients maximum. Then the other challenges in the mucormycosis management, we all know there are more than 23 species of mucor which can infect the human being or infect the human being. And the biggest tragedy was there was lack of any species identification. Every species has a different course of disease, different spread, different virulence, different prognosis, different treatment, different sensitivity to the antifungal drug. And all surgeons, treating physicians were absolutely blinded to this fact. Then there was no culture sensitivity of the drugs to treat this fungal infection as compared to treating the other infection like any other bacterial or fungal infection. And again, we never know what drugs is working to what level, what are MIC values, and everything was again blinded. Then it came out all of a sudden in large numbers. There were no uniform treatment guidelines. Earlier, we could we did see mucor sporadically once in a while, but not in such a way. And this mucor was typically affecting an immunocompromised people, and this COVID itself made the people immunocompromised, and this mucor was very, very virulent at times. So all the challenges, particularly in patients who itself were challenging, majority of the patients were diabetic, multi-system disease, were totally medically challenging patients. So overall, the scenario was very, very, I would say, depressing in treatment of the mucormycosis. And this was a list of, various species which can infect the human being, and we were totally blinded out of it. The drugs, as far as the drugs were concerned, again, the scenario was depressing. As the drugs, the main drug, which is considered to be the most potent one, liposomal amphotericin was out of the market. The scarcity took a lot of lives that time. The other drugs which were considered to be effective, isobuconazole and posaconazole, there were no fourth drug you can say which can be considered effective for mucormycosis. And again, as I said, we were totally blinded which one is effective on which particular patient. And we had a couple of patients wherein even the amphotericin was resistant. Though there was no culture studies done on all patients, but we could see in spite of amphotericin administration, in spite of best surgery, and the disease was progressing, and ultimately switched over to the other drugs, and then it came under control. So these were the biggest challenges. MRI, why I opted this topic, the MRI emerged as a life-changing, game-changing tool to deal with this situation in terms of establishing diagnosis. Not only early diagnosis, establishing diagnosis, because involvement of the paranasal sinuses was the earliest, and it was so difficult to differentiate from the regular normal sinusitis to mucormycosis sinusitis. And there was certain MRI changes based on various, sequences of the MRI. One can easily pick up whether it is mucor or not, which is not possible otherwise with any other radiological investigation. CT scan, what to talk of, it can't give even 1% of the information what MRI can gives us. Then the most important role of the MRI was in surgical planning. We all know mucor preferentially affects the vessels and gives vascular necrosis. And whatever the necrotic areas, because of the lack of vascularity, this fungus grows, it gets the optimum environment, hypoxic environment for the growth and propagate further. And in that situation, the antifungals do not penetrate because of the lack of vascularity. So in those situations, with necrotic areas, the antifungals not penetrating, the only thing which can save the life is to remove all those necrotic areas. You can consider enhancing areas where the contrast is going, whether you can assume your drugs are also going, and you can consider medical treatment for those things. But all necrotic areas must be removed as early as possible to prevent propagation of the disease. And that could be decided best on the MRI, wherein the contrast MRI will show dark necrotic areas without any vascularity, where the contrast is not reaching. And those were the times those surgical areas needed to be completely debrided to save patient life. So the extent of surgery was again dictated by the MRI best. Then the kind of surgical approach where the surgeon is going to use is again dictated by MRI. It depends upon the, MRI will tell you exactly where the disease is progressing. This disease, starting from the paranasal sinuses, would very fast progress to the surrounding areas, to the infratemporal fossa, pterygoids, to the orbit, and then orbit is a gateway to the brain. So it could progress very fast to other areas, and MRI could actually pick up the exact extent so that the surgery can be planned and the surgical approach can be planned. For those who are well versed with the endoscopy, skull-based surgery could do majority of the cases endoscopically, otherwise open approach was the other alternative. For those who are not experienced, were not equipped, but saving the patient life is important. And on the basis of the MRI, one can plan your surgical approach exactly to tackle that particular extent of disease removal. Then the follow-up also, as I said, the antifungals, the effectiveness of the antifungal was question mark. So what you can all do is remove the necrotic areas, rely on the non-necrotic or enhancing area on the antifungal, and then follow closely on MRI in spite of the patient being asymptomatic in the post-operative phase, to pick up early keep following with the MRI to see any disease progress. If the antifungals are not working, the disease is certainly going to progress. And if you can pick up again with the MRI, you can again clear it surgically and switch over to other antifungal to save the patient life. So follow-up, prognostication, everything was dictated by MRI best. Prognostication, why I mentioned, because from the initial MRI, you can pick up the exact extent of disease, whether it is involving the orbit, brain, how much orbital apex is involved, how the vision is, the possibility of vision saving is there. So all these things you can prognosticate based on the basis of MRI. So you can tell your patient in advance how the patients are going to behave. Otherwise, it can invite medical legal issues. So the MRI is very, very important. And there are certain preferential areas we have come to know in our series of more than 400 cases we did this year of mucormycosis. These are the preferential areas we saw where the disease was involving, progressing, and these were the areas where we needed to keep an eye, particularly on the MRI, to see the earliest pickup, so that we can deal it earliest to save the patient and give him the best results. So this was about the MRI, and I am going to give you certain examples now that what MRI, how could MRI help us this much. Now, the onus on, again on the surgeon, that what MRI sequences to order, because what if you prescribe or order MRI PNS, it is not going to go. So, now, are you getting? Yes, I think you are getting the MRI now. So the onus on the surgeon to order particular MRI sequences which can pick up the disease. Otherwise, if you have an incomplete MRI, even with the MRI in hand, you can miss the disease, and again it is a disaster. So there are certain sequences we must know that how MRI can pick up, and the best thing, the best sequences are the T2 weighted fat suppress, number one, and then T2 weighted and the contrast MRI. Let me show you what is T2 weighted. See, this is T2 weighted imaging. T2 weighted, highlights the fluid as a high signal or the bright signal, and at the same time it picks up the inflammation as a high signal. That is most important. Now, we all know in all MRI sequences, fat gives a bright signal. Now, with the fat giving bright signal, suppose you are in the orbit, with the inflammation going in the orbit, how can you differentiate? There is no way. The best way to differentiate is to get the fat suppressed T2 weighted. Now see what is fat suppressed T2 weighted. See the difference between these two sequences. Fat suppressed and non-fat suppressed. This is regular T2 weighted. This is fat suppressed T2 weighted. Now look at the orbit. The fat is suppressed, and now if you find any enhancement in the fat suppressed T2 weighted MRI, you can assume it as an inflammation. And in the patient of mucormycosis, where you're suspecting that inflammation is mucormycosis. So in fat suppressed imaging, if you find any inflammation, any brightness, that you can consider as an inflammation. Number two, bones. This mucor has a tendency to invade the surrounding bones, particularly alveolus, upper alveolus, palate, sphenoid bone, and the marrow of the bone was replaced by the fungal disease. Now, how can you pick up early? See on the fats, let me give you, this is the T1, regular T1 MRI. See this, in T1 weighted MRI, see this alveolus. The alveolar marrow is highlighted. It is hyper intense, a normal marrow on a normal non-contrast T1. See, going to the pterygoid, see what is highlighting? What is hyper intense is the pterygoid bone marrow. Now see, in a fat suppress, since the marrow contains fat, it has suppressed the fat and it appears dark in a normal person. Now, even in the fat suppress imaging, if you find in the bones enhancement, in a fat suppress imaging, if you find in the bones enhancement, that means you can assume it is inflammation. That is how you can pick up whether these bones are involved or not, because this bony involvement is the key to the success to handle the bony involvement, because there is hardly any penetration of antifungals in the bone, and you have to pick up yourself rather than relying on the radiologist, because radiologist can give you an idea that the pterygoid is involved, the palate is involved, but they can't tell you exactly without sitting with the radiologist or without you see yourself, the radiologist, that how much is involved and how much you can save. Because if you unnecessarily remove the normal area, the morbidity, you are inviting more and more. So to prevent the morbidity at the same time, to plan your reconstruction, actually the surgeon should have a complete information that how much the disease is involving the bones, palate and all these, how much the part is need to be removed and how much the morbidity is expected, so that you can tell your patient, and how much reconstruction is required. So all this planning is based on the MRI. So this was a normal MRI. On contrast also, the another important thing is contrast. Why I said contrast? On contrast, you have to pick up any areas which are not enhancing, which otherwise are enhancing on T2 weighted fat suppress. That is the bottom line to detect mucormycosis. The other sequences I'll tell you when they are required, the diffusion and all. In instances when the bone, when the orbit and the brain is involved, to see the parenchymal invasion, to see the optic nerve infarct, then your diffusion and the flare imaging is important. But by and large, T2 weighted fat suppress, contrast, and plain T1 are the sequences by means of which you can pick up easily the mucormycosis earliest. Now, how to differentiate the mucor from the other cases? Let me tell you this example. This is the left side, the maxillary sinus, with the sinus, mucosa enhancing, and the secretions not enhancing. See the secretion which may enhance on T2 but not enhancing on contrast, but the mucosa, the lining mucosa is enhancing. Since mucosa invades the sinus mucosa and go outside, you would never find a lining mucosa enhancing. Look at the opposite side in the same patient. Look at the lining mucosa is gone, necrose, and see if I go behind, the lesion has gone beyond the maxillary sinus to the infratemporal fossa where it is enhancing on fat suppressed T2 weighted, otherwise which doesn't enhance. See the necrotic tissue which is not enhancing on contrast but enhancing on T2 fat suppressed, that cannot be anything else than mucormycosis in this scenario. See, you can identify on the basis of mucosal enhancement whether it is mucor or not. Whether it is mucor or not, you can identify very easily, which other radiological information, CT scan or other thing, you can't even think of getting that much of information. So this is important to establish the correct diagnosis, early diagnosis of the mucormycosis. Now, once you have established the early diagnosis, the next important thing is to pick up whether it is, how the disease is extending. There are situations, I will give you certain examples, where the early diagnosis was so crucial. Your endoscopy was negative and yet there was a mucor disease. So another example of mucor sinusitis and non-mucor, let me skip this. See this, let me go quickly. This is the fat suppress imaging. Yes, see the enhancement on T2 wet fat suppressed, but we do not know what exactly it is, whether it is mucor or not. Now see, on contrast, the mucosa has gone and disease has gone beyond the confines of the paranasal sinuses and has even come into the soft tissues. See, it has come into the soft tissues in necrotic areas, and see how it is enhancing on T2 fat suppressed. The fat is already suppressed, whatever enhancing is inflammation, and see it has gone beyond the confines of the paranasal sinuses. It cannot be anything else than mucormycosis in this scenario. So diagnosis whether there is mucor or not, to differentiate whether it is a mucor sinusitis or other regular sinusitis, it is very, very important to go to the radiology, particularly to the MRI. Now this is another classical example which was missed by many people. This patient had mucormycosis. The surgeon got the CT scan done earlier somewhere. The nasal endoscopy, see, absolutely clear. There was nothing on nasal endoscopy. One can easily miss this lesion, but when we got the MRI done, went behind. Look at this. Look at this. What is there? What is this enhancing on T2 fat suppressed? And see, there's a lot of necrotic areas in the pterygoid region, greater wing of the sphenoid, pterygoid process and the sphenoid. And this is what enhancing on T2. On contrast, lack of enhancement, Nasal endoscopy, absolutely negative, no nasal finding at all. And yet the patient was having mucor in the depth. So there are, see, classical examples how the MRI can pick up all these lesions. Another example, because these patients, if not picked up in time, this disease is fulminant, it spreads very fast, and it is difficult to save the lives of these patients. Now, another example, this particular patient, I can never forget, had little bit some mucosal edema, sinusitis, but on CT scan, it was normal. Just little bit patchy sinusitis, that's it, and had headache. We got the MRI done, and what we found, see, there was nothing in the nasal cavity here significant. The roof of the ethmoid necrose, the cribriform plate necrose. We explored this patient. We did a combined approach, removed the entire cribriform plate, with a combined approach from bifrontal craniotomy and below. And it turned out to be mucor. And after the antifungal, we could save this patient. This earliest involvement with nasal endoscopy negative, your CT scan showing nothing, and yet there was a mucor.
Dr. Satish, your slides are not moving. Are you showing the? This is showing the MRI of Devi. 66. Is it the same MRI? The scans are not moving. Are you showing the scan of Devi, 66-year-old female? It's not moving. Some of the things which you're saying doesn't correspond with the MRI images.
Okay, when I speak, the same thing doesn't correspond on the scans.
Yes, sir, because I think the slides are not moving.
It could be delay in the both the things. They are not going together. The scan and voice. Yeah, this is what I'm skipping. And the voice is going early. Let's see. So we are trying. Let's see. So now moving further, there is another example quickly in next 5-10 minutes. Why it is not going? Now probably it is going. Yes, sir, it's sorted out. So now this is another example. We saw palatal involvement was very common in mucormycosis, and one could easily miss the early palatal involvement. The fact is, once the palate is involved, when the bony palate is involved or the fungus is invaded the bone, you can't expect the antifungals to work effectively. And for those, the only answer is to remove that necrotic bony area at the earliest. The question is how to pick up that earliest lesion. In CT can differentiate how you can pick up. That's the only thing. Otherwise, what happened? We have seen many of the patients came to us later on for the palate removal after the previous surgery done. When the palate disease manifested, they came later on, and then the second surgery for the palate removal was done. See this classical example, we can't forget in life. This patient, see T2-weighted fat suppressed. See the alveolus, upper alveolus on the left side on fat suppressed, it should be dark and the bone marrow is suppressed. See on the right side what is there. See on the right side, the alveolus is enhancing, and this was removed and turned out to be mucor. On surface, it was absolutely normal with no disease looking like, and had we not removed this palate that time, it would come later on for the second surgery, and that would give opportunity for the fungus to grow further areas also. So this is how the early diagnosis of the palatal lesion is very, very important for the better results. Whatever. Yes, it will go now quickly. Now this patient again is a very, very important patient who presented with bilateral palatal involvement. That is so unfortunate on the patient's part to have a bilateral upper alveolus involvement. The reason being you are not left with any choice but to remove the alveolus completely to save the life. And this patient, see this on T2-weighted, see the entire upper alveolus bilaterally involved. That is something you may not find clinically so easily there, but what MRI is showing the complete involvement of the bony alveolus bilaterally, made us to remove, see the complete necrosis of the upper alveolus bilaterally, and we removed it completely to save the patient. It's been long back, and after 4 months now, we have reconstructed the entire bilateral upper alveolus with a free fibula. So the bottom line is exact extent of involvement of the palate is very, very important. So you can plan your surgical excision timely to prevent any, the need of the future surgery. Now is the important for the orbit, because orbit is frequently involved in the mucor. We have seen the question mark is how to deal with the orbital pathology, where there's an option of orbital exentration, at the same time orbital clearance, preserving the bony eyeball. Eyeball was not involved in many of the patients, and on those patients, unnecessarily removing the entire orbit would be too much of the treatment, I would say. So now there are certain examples I would share here of certain patient who had limited orbital involvement. See this patient had limited orbital involvement behind. Involvement of the paranasal sinuses, see the maxillary sinus, it provides limited orbital involvement, but not involving the eyeball anteriorly at all. It would be, I would say, not justified if you unnecessarily remove the entire orbit and do an exentration for this pathologies which can be cleared, preserving the orbit. The vision is a different thing, but preservation of the orbital structures, the eyeball for cosmesis is equally important. And this is how this decision can be taken easily on the basis of the radiology. Now I tell you, when the orbital exentration is, there is no other option than orbital exentration. See this patient. See the normal eye on the opposite side and see the situation of the eye on the opposite side with gross involvement of the entire orbit, right from anterior to posterior, including the eyeball, sclera, eyelid, everything were involved. And that is the classical example of a patient wherein the orbital exentration is the only answer rather than thinking of anything else into the orbit. Now, there are situations where the patient presented with partial vision loss or incomplete vision loss or sometimes sudden vision loss, and it was unexplainable on the basis of the disease. How could the vision loss happen? And we did in certain patients this MR angiogram, and we could find some interesting findings. See, this angiogram can show you the ophthalmic artery going to this side, but here the ophthalmic artery got thrombosed with no sinusitis in the paranasal sinuses, and see this ophthalmic artery completely thrombosed. This is one of the manifestations as the mucor gives thromboembolism, and this could be picked up early in the scores. And this was most of the difficult cases to manage, whether what to do with the orbit in those situations when the ophthalmic artery is thrombosed. We can pick up such patients early also on the basis of the diffusion also. See, when the ophthalmic artery thrombosed, let me show you what happens. You can pick up on diffusion. See, this is the infarction of the optic nerve. One can see the infarction of the optic nerve early, even before the clinical blindness completely settles in, and that's how it saves you from the medical legal issues. The patient who is going to lose his eyes very soon, almost losing, presented you before you started operating, and then post-operative phase you find the orbit, the patient lost the vision, and the patient may fall upon you. So all these things are important to know on the radiology, that which sequences are important and which are to be seen in that particular patient. Now see, this particular patient, see, every patient has a different extension, I told you, and we had a lot of surprises in many of the patients. I show you. Okay. Let me open. I have opened many windows. Okay. See, this patient is again unforgettable. What an extension of the disease this patient, and a lot of lessons we learned out of this. This patient had most massive extension of the skull base, one of the case which had complete involvement of the clivus. See, look at the clivus, sphenoid, pterygoid, greater sphenoid bilaterally, and then the temporal region, the temporalis muscle, the mandible, the mandibular condyle, everything was involved. There's a young chap, 36-year-old Ashish, we can't forget. See the occipital condyles even, and we had to undertake a long surgery removed everything, part of the condyle, part of the almost entire clivus, the mandible, the part of the mandible, temporomandibular joint, part of the temporalis, bilateral greater wing of the sphenoid, even the carotid went, see this side carotid, the opposite carotid had gone in spasm, and by all means, we never predicted how it is going to be, and with the amphotericin and then posaconazole, this patient is now, we can claim it as a cure to this patient after 6 months, and this was the extension, and MRI could help us where exactly, see how the temporal region was involved, and the entire temporal region, we had to remove completely and reconstructed with the free flap for the entire depression in that region. So the issue is the involvement you need to assess thoroughly by means of MRI so that you can identify everything. This patient, look at the infratemporal fossa involvement, massive infratemporal fossa necrosis. You can see bilateral complete palatal involvement, bilateral greater wing of the sphenoid involvement. See what knot is there. See the complete infratemporal fossa, entire infratemporal fossa muscles were involved and were necrosed and removed like anything. Complete palate bilaterally, you can see it was gone. See the situation of the alveolus and the palate, and the greater wing of the sphenoid sinus, and such examples are those where the MRI could help us dictating that what is the extent of surgery, so we could save these patients. And lastly, about the intracranial part, some of the classical examples I would enumerate here quickly. This patient again is something to mention, because this patient, let me put the contrast. Yes, this patient had, after the had undergone surgery somewhere twice, and then came to us with a brain abscess sitting in the roof of the ethmoids and the sphenoid. This is frontal base brain abscess. Had multiple abscesses, I remember. And these brain abscesses are the classical examples where you can think the antifungals are not going to work. Thick-walled brain abscesses, another abscess in the region of the tentorium there in the occipital lobe, multiple brain abscesses, and there is no other answer but to remove these abscesses, thick-walled abscesses where the antifungals are never going to penetrate with the necro material inside. And the only answer to save this patient is a surgery, and they required open surgery. We had more than 80 patients we operated with intracranial involvement with different funny extensions, different surprising extensions, I would say. This patient again is an example, and we had seen this kind of extension in many of the patients where the frontal bone was involved. This is something preferentially involved in many of the patients. See the entire frontal scalp and the frontal bone. The bone is classically dark on MRI, and see this bone enhancing with a lot of lesions, fungal lesions inside with a dural involvement. And this, everything was removed and blocked with reconstruction with a, artificial bone. And this we had to do in almost 30 patients, and where the bone involvement was there, and we had to remove the entire intracranial fossa, frontal bone, and many of the things. And this is important, otherwise this is bottom line. Whenever there is a bone involvement, your antifungals are never going to work. This is bottom line. So whenever there is bone involvement, we must think of radical removal, otherwise nothing is going to work. Because of the close proximity of the lesion in the orbital apex, we had seen many of the patients with carotid thrombosis. Look at the thrombosis in the carotid artery. This is the normal carotid artery and the thrombosed carotid artery. And many of such patients presented to us with the, hemiplegia also, with the carotid, thrombose. And these were the poor patients. We couldn't do much to them when there is disseminated involvement of the, the intracranial structures. And this is one of the examples I'll give you. See this patient, the carotid was thrombosed on this side, had multiple infarctions in the brain. We couldn't differentiate whether it is a mucor or the regular infarction, and ultimately patient couldn't do well very soon left. And this is, there are various variety of, involvement of the intracranial space. This is another example where you can't think of giving any treatment. Disseminated. There cannot be a better example than this for labeling a disseminated disease, when the disease was going everywhere in the part of the brain. And see, this is the massive involvement of the paranasal sinuses, all bones orbit completely gone, and then the huge brain abscess in the temporal lobe, then the brain abscess even in the the brain stem was the abscess there, and this is something untreatable for anybody on this planet. And these are the examples where you have to ultimately leave all hopes and tell your patient quickly. Now, this is the last example where I must say this is very, very important, the role of MRI. Many of our patients with ethmoidal roof involvement had cribriform plate and dural involvement. And this go unnoticed. You can easily miss. CT can't pick up. Only the MRI, by means of MRI, we could pick up this early dural or cribriform plate involvement. And this is so important because once the dura is involved, the penetration of the antifungals is very, very poor. And that too, you have to give for months together, and that too with poor penetration. And the only thing which can work in this situation, see, the dura was involved in this patient. We could see endoscopically after the, the nasal part done, the cribriform was necrose. And for this, we did a bifrontal cannot combined approach with our neurosurgeon. And I'm grateful to our neurosurgical team led by Dr. K.K. Bansal here. So we did a couple of, massive neurosurgical cases combined approach, and many of these patients are doing well. So these are the classical examples wherein the MRI can pick up the early dural involvement, and you can take a combined approach, with the bifrontal craniotomy to remove the cribriform plate in toto and reconstruct the skull base. So the MRI can tell you your path, exact path for the treatment, that what exactly is required to be done in the particular situations. Thank you so much for your attention. Thank you very much once again for this privilege and honor. Thank you once again.
Yeah. Thank you, Dr. Satish Jain, for giving the prestigious Dr. H.V. Suranaran Rao oration. During the COVID has taught us many things. As ENT surgeons, one of them is the management of mucormycosis. And we are grateful to you for your surgical workshops and the videos which you put up, which has helped quite a few of us in the surgical management of mucormycosis. Today, you gave a very lucid and very interesting part of mucormycosis, that is reading of CT scans and the MRI, especially for mucormycosis, the importance of the MRI, both the pre-management and the prognostication of it. We thank you for that. Thank you. Thank you, sir.
Thank you so much.
Shukri sir to present memento to the moderator.
Hello. Hello.
Demonstration of same-stage subtotal petrosectomy with cochlear implantation in 1-year-old child. We'd like to call upon Dr. Jyoti Swarup sir, Professor and HOD of Siddhartha Medical College, Tumkur. He's a president-elect of AOIK Karnataka.
And we would also like to call upon Dr. Somsundar sir. His MSENT, he finished it from BMCRI Bangalore. And currently he is Surgeon General, Senior Specialist in Health Sciences and Family Welfare Department by the Government of Karnataka, Secretary and Treasurer of AOI Mysore chapter. Sirs, kindly come forward and chair this session, sir.
What happens, sir? Unmute yourself. Unmute yourself.
Yeah, welcome all of you for this light surgical workshop. So we are getting picture in picture from the OT.
Sir, 1 second. Sir.
Good afternoon, sir. Dr. Satish Jain, sir. I think sir has gone for washing.
Yeah, am I audible? Hello? Hello?
This is a child with
Hello?
metrositis.
Hello? No. Hello?
Hello, anybody from OT? Can you hear?
Yes. Can you hear me, sir? नहीं जा रही आवाज नहीं जा रही आवाज पूरा आवाज नहीं जा रही है हेलो हेलो आवाज नहीं जा रही है कौन है हेलो हेलो नहीं जा रही ना नहीं हेलो 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 हेलो
हेलो हेलो सर। अब ये माइक से भी नहीं सुन रहे वो लोग, मतलब वहां पे नहीं, स्पीकर पे नहीं लगाया उन्होंने, ये वाला आपके माइक पे है।
क्या करूं मैं, सॉल्यूशन बताओ। हेलो हेलो से ऑडियो जा रहा है, उधर से कोई कम्युनिकेट नहीं कर रहा, उधर स्पीकर ऑन नहीं है। Going from here. हेलो हेलो हेलो
Hello.
Yes sir, can you
Hello.
hear me?
Hello, sir.
Yes, can you hear me?
Hello.
Am I audible, sir? Hello, sir. Hello.
Yeah, just for audio here. He's telling audio is going from there. From their side.
Hello.
Just keep the check ಮಾಡಿ.
Hello. Hello.
Hello.
Hello.
Yes. Yes, sir.
Can you hear me now?
Yeah, yes, sir. We can hear you. We can hear you.
Okay. So we are all set with the live surgery case here.
Fine.
And as I mentioned, this case is going to be a 1-year-old child for cochlear implantation with simultaneous subtotal petrosectomy approach. We'll discuss here why subtotal petrosectomy for such a small child and the reasons and indication for that. Can you hear me now?
Yes, sir. Yes, sir.
So for this case, we are here at the state-of-the-art Narayana Multi-Specialty Hospital in Jaipur, where I operate on a regular basis all complex cases. And this is state-of-the-art center. You know Narayana well in Karnataka, in Bangalore, the same in Jaipur. And with us here, our clinical director, Dr. Pradeep Goyal with us, who is the head of anesthesia department here. And they are amazing people with, kind of anesthesia giving to every possible complex case here. So this particular patient, thank you, boss. Thank you everything to the team Narayana. And with me, my colleague here, Dr. Dipanshu, who is an ENT surgeon, senior ENT surgeon here at Narayana. So this particular case, we all know cochlear implantation has revolutionized the rehabilitation of hearing impaired children, particularly children who have profound sensory neural hearing loss. And for decades now, this implant has established its role to rehabilitate those children. Now, with the time, with better understanding of the implant technology, anatomy, and other things, and the encouraging results, the indications are expanding for the implantation. Earlier, when to begin with, the implantation was directed to children with certain criteria of 85 dB hearing loss, this much of score and that, only for those children. The implantation was reserved for those children only. But now with time, the implantation, if you ask me the indication, I hope I'm audible. Hello?
Yes, sir. Yes,
so
sir.
now in the present context, if you ask me the indication for implant is for everybody with sensory neural hearing loss to the level where the hearing aid doesn't benefit. So any patient, may be child or adult, where the hearing aid is not able to benefit the amount of sensory neural loss the patient is having, the implant is the answer. As simple as that, irrespective of any other indication or classification. Now in this series, the indications are more and more expanding to rehabilitate those patients who lost their hearing or the disease or the tumors, taken their hearing, and the skull-based surgery contemplated. So now the implant can be possible at the same stage or afterwards, the lateral skull-based surgery, provided the basic functional unit intact. So what is basic functional unit? A fluid-filled cochlea, an intact cochlear nerve. That's why we get the MRI done, to know whether the cochlea is fluid-filled or not, or whether the cochlear nerve is intact to take the signals to the brain. This is the basic function unit which is required to be intact. In spite of having done any major skull-based procedure, if this basic functioning unit is intact, you can still do a implantation. Similarly, the expansion with the advancement in the surgical technique is to rehabilitate those patients, children or adults, who have chronic suppurative otitis media and lost their hearing, profound sensorineural loss, or those who are having repeated ear infection, some pathologies which can lead to ear infection in future, who are likelihood to have developed ear infection. Those were the candidates for the implantation. Is, you know, something you have to think twice before implanting those patients, that the implant in an infective field or the patient develops infection later on, the implant can, you know, is at a stake, and the patient is at the stake of developing meningitis in the future as you open up the inner ear avenues now after opening the cochlea. So those are the difficult patients where the implantation is considered very, very difficult. But now with the introduction of this technique of subtotal petrojectomy for the implantation. Subtotal petrojectomy is not a new technique. It was introduced way back by Hugo Fish to exenterate all possible air cells in the temporal bone with closure of the extra-aortic canal, removal of all skin, mucosa, everything with the temporal bone, closure of the extra-aortic canal, and closure of the eustachian tube. If this technique is applied for selected patients for cochlear implantation, this can be a boom, and it has established its role. We have done number of cases of subtotal petrojectomy implantation for different indications, which I'm going to enumerate with you, share with you today. And this case particular is a 1-year-old child, bilateral profound loss, had cleft, submucous cleft palate, developed secretory otitis media again and again, and some episodes of acute otitis media as well, and is a candidate for cochlear implantation. And now imagine if you implant this child and the infection, recurrent infection develops because of the otitis media later on, with the implant in situ, what is going to happen? The recurring infection with the implant in situ will make implant at stake. Number one, implant being a foreign body will ultimately develop biofilms, which is resistant to all possible antibiotic treatment. And then you have to ultimately explant the patient, otherwise the patient is at stake of developing meningitis. So in those group of patients where the patient is likelihood of developing infection in the future or getting recurrent infection, the best technique to adopt and best is for such patient is to adopt a technique wherein you can avoid infection entering into this field again, and that is what the subtotal petrojectomy. You can exenterate all air cells, remove all skin, everything from the temporal bone, block off all the connections of the temporal bone from outside to enter the infection in future, close the extra-aortic canal, block the eustachian tube, put your implant, obliterate the cavity with the fat, and you can prevent possibly all sources of infection coming in the future of the temporal bone. This technique is justified because once the patient has a profound hearing loss and likely to be implanted, the middle ear and the external ear has hardly any role or no role in the hearing mechanism now after the implantation. And if you adopt this technique, you practically block off all external connections to acquire infection in the implant field, and the possibility of explantation is certainly something you can avoid. So this calls of a special technique called subtotal petrojectomy, and we can do it same stage with the implantation. So this is one example for which we are doing. We have been doing for many other examples. That is what I want to share with you in next 5-10 minutes. And then we'll go with the surgical procedure. The patient is ready. I can see Dr. Deepak Haldipur on screen. I think
yes, boss.
He's in Bhopal.
Hi.
Hi, boss.
Hi. Sorry. Suddenly DCR suddenly they told me to demonstrate. I'm back again with you. I'll be with you for the next 2 hours. Go ahead.
Thank you. So nice of you. It's always a pleasure being with you. It's a learning experience all through, and you've been, backbone of my learning and shaping my life. I would say the credit goes to Dr. Deepak Haldipur. Maximum.
And,
Thank you so much, boss.
you are the greatest teacher I've ever met in my life. The whole world knows what difference your teachings made to my career and my life.
So great you are, I would say. So this particular situation, subtotal petrojectomy with implantation, it's the same stage. What we are offering to this patient is basically to prevent recurrent infection which the patient is acquiring because of the submucous cleft palate. We all know cleft palate patients are prone to develop recurrent medullary infection, secretory otitis media, as their eustachian tube malfunction is obvious, and those patients are likely to develop CSOM in future. Now, if you do a regular implantation to rehabilitate such a child with a regular cochlear implantation and a patient develops infection again, what is going to happen? The infection is very, very difficult to control with a foreign body in place, and then the patient is at a risk of meningitis also, as you have already opened the avenues of cochlea and for the subarachnoid space, and then ultimately you will have to explant, and that is a disaster. So in order to avoid all these possibilities in patients who are likelihood to develop infection, the best answer is to adopt a technique wherein you practically create a sterile field for the implant for life in the temporal bone. You block off all connections of the temporal bone from the external world by means of obliterating the eustachian tube, external auditory canal, and obliterate the entire cavity with the fat covering the implant. You can practically be rest assured for life, as the infection is not going to come back. The thing which required is to adopt a proper technique to execute it properly, excentrate all cells, read radiology properly, how you can do it. So the indications for subtotal petrojectomy, beside this particular case, I will quickly take you. So as I mentioned, to deal with the chronic medullary infection, as you prevent all possibility of infection in the future. Secondly, the situation wherein the cerebrospinal fluid leakage is there. In implants, there are situations, malformations where we have been implanting, and there are certain malformations which have a high likelihood of giving a CSF leak, like IP1, IP2, IP3, or common cavity, all those situations. So you can handle the CSF leak by a regular method, by packing with the fat or anything. The best way to handle a CSF leak is to obliterate the cavity. There cannot be any better way for future, for life, and we can rest assured the infection is not likely to enter in this field. So there are many indications besides the infection, the CSF leak prevention. You can keep your electrode arrays more secure with a fat obliterated cavity to prevent migration, slippage of the electrode array, and all those things, particularly when you do a drill out. Suppose you are doing a cochlear drill out, keeping the electrode arrays in place is again a big challenge. And in those situations, once you obliterate the cavity, it takes care of everything. So overall, it helps to reduce the extrusion of the array. Indications are many. All possible chronic suppurative otitis media patient with, profound hearing loss, maybe patient having central perforation, cholesteatoma, radical mastoidectomy cavity. We can do, if the active infection is under control, we can do same stage subtotal petrojectomy and implantation, which will take care of the chronic suppurative otitis media part as well, along with the hearing rehabilitation without any issue, provided the active infection is taken care of. If the active infection is not taken care of, you are not sure of the infection being taken care of, and you don't want to delay much, what you can do, at least do a subtotal petrojectomy and obliteration and come back after 6 months or so for the implantation in the sterile field. So both ways you can do, but you can do same stage to avoid delay in implantation, particularly in children, which can negatively impact their, overall hearing outcome. Then the cochlear ossification is another example. Believe me, we have been doing cochlear drill outs for many of the difficult ossified cochleas. Now, what happens if you are doing a drill out for a narrow posterior tympanotomy? What can happen? You don't have access of the, to identify the surrounding landmarks. Most importantly, vascular landmarks. We all know just anterior to the cochlea in a millimeter distance is the internal carotid artery. If you are doing a drill out of the entire cochlea, your carotid is in close proximity, and controlling the carotid through that narrow posterior tympanotomy is always
Hello. 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 Hello, Dr. Satish Jain. Hello, we have lost the picture. Hello, anybody in the OT? Here we are not getting any picture or voice.
audible, sir?
Now
you are audible. Am I audible?
Fine, fine, we got it.
So, for the indications like fractures, temporal bone with profound hearing loss, as the fractures do not heal with bony reunion. The fractures heal with fibrous tissue, and possibility of meningitis is always there. And if you put an implant, always take care of this aspect to prevent meningitis, to do a subtotal peterectomy at the same stage. So there are such osteoradionecrosis, post-radiation therapy. These are situations when the temporal bone is mostly avascular, and and the possibility of infection is more. And implanting such patients where the profound hearing loss is still possible if you do a subtotal peterectomy and obliteration, particularly with a vascularized flap to take care of the vascular aspect as well. So these are the situations where earlier implant was not possible, and now with this approach you can rehabilitate all those group of patients if you can do a subtotal peterectomy. After any lateral skull based surgery, provided your basic function unit is intact, you can go ahead with the subtotal peterectomy implantation in the same stage. You can do at the same stage, provided there is no active infection. Revision surgery, unfavorable anatomical situation, revision surgery, you're not sure of the anatomy anywhere, go with the subtotal peterectomy. It opens up like book. Everything is open in front of you. To identify the landmark is the easiest way, I would say, once you do a subtotal peterectomy. And this is the condition, this is the situation, this is the technique which helps you overcome all these difficult situations in your practice. So the basic problem in the CSOM is risk of returning infection, which can lead to labyrinthitis, meningitis. And then in this situation, suppose you have operated for a CSOM. Let me give an example. A patient has this is our proposition. Patient has a central perforation. You operated, do a meringoplasty, tympanoplasty, and after 6 months or so, you come back for the CI. Most of the people do this. Now, what can happen? The chronic suppurative otitis media requiring tympanoplasty. How is the long-term success rate? Though we know the success rate is good initially with more than 90%, but you pick up all the series in the world, the long-term success rate drops up to 70%. Why? Because you have no control over suppurative otitis media. You don't know in detail why that particular patient developed the chronic suppurative otitis media, and it can come back again in future. And what happens in an implanted patient developed infection later, it warrants explantation most of the time. So any patient operated for CSOM, as CSOM wants implant, best to do a subtotal peterectomy, because ultimately the middle and external ear are not going to participate in the hearing. You can sacrifice that and do a subtotal peterectomy and create a absolutely infection-free environment where your implant can reside. So this is something, this is the environment which I'm going to show you. See, the entire cavity filled with the fat, the extra aortic canal completely closed, the Eustachian tube is closed, and the implant is lying in the sterile field. Yes, sir.
We are not getting the CT film.
PPT?
CT film. That
PPT, you are not getting
not PPT, sir.
CT film, sir.
Yeah, maybe now you are getting. Are you getting now? Are you getting the PPT?
Yes, sir. Yes, sir. Yes.
So this is just to depict how subtotal petrojectomy is and how the implant resides in a sterile field. Your Eustachian tube is blocked, your external canal is blocked, you blocked up all outside source of infection to the temporal bone. Your implant goes in the cochlea in the very, very sterile field covered with the fat all around. That is what we want to create to prevent future infection. Now, all sorts of CSOM you can tackle, particularly canal down. Suppose you have a patient with a canal down mastectomy done with a profound hearing loss. Now, what can you do? If you implant by means of elevating the epithelium and putting the implant under thing, what happens? The canal down cavities very frequently acquire infection, or you need to clean the cavities very often, which can expose your CI. Your CI can acquire infection underneath the epithelium, and that cannot work. And a patient who has been implanted with a lot of cost and everything involved, that is never a good proposition. The best is to do a subtotal petrojectomy, same stage and implant and obliterate the cavity. That is how this can work in all those situations. Like I mentioned, this patient particularly has a Eustachian tube dysfunction due to submucous palate, cleft palate. See, these are the patients with high risk of developing ear infection. Suppose your patient has a persistent, allergic rhinitis, chronic sinusitis, and profound hearing loss, wanted implant. Considering the long-term proposition, we should think of subtotal petrojectomy and implantation to prevent future infection getting into the ear. See, if you don't do this and patient unfortunately happens to get the infection in the ear later on with the implant in situ, then it is a disaster. And most of the time you ultimately end up, explanting the explanting the patient with the implant. So these are various situations. I will skip. Now I have already mentioned about the inner ear finding, inner ear malformation. There are situations, particularly IP1, 3 and common cavity. If I am doing, I would almost always do with the subtotal petrojectomy implantation for the regions that in malformed cochleas, you have the identification with the landmarks sometimes is difficult. So subtotal petrojectomy offers you the best opportunity to identify your landmarks. More than that, it controls the CSF leak most effectively by means of obliterating the entire cavity, and the overall incidence of meningitis is much less, particularly in IP1. You know what happens in IP1? Besides the cochlear malformation, IP1 is a stapedial footplate malformation. There's a cystic-like structure formed because of the faulty footplate, and that keeps on leaking the CSF. Patient can acquire meningitis with no implantation done even. So IP1 patient has a high chance of developing meningitis on its own. And this is the technique if you are operating. If you have an IP1 patient, at least do a subtotal petrojectomy and obliteration to prevent future meningitis. And later on, if the patient is not getting implant, now you can implant later on, just open up, elevate the fat, implant, and come back in a sterile field. So that is what the desired proposition in such patients. So these are the indication, and indication, believe me, are expanding nowadays with all ossified cochleas. Autosclerosis, far advanced autosclerosis, obliterating cochlea. What you can do, how can you identify the cochlear lumen, all that. You need drill out, and the best during the situation of drill out to protect around everything, carotid artery nerve, you need a subtotal petrojectomy. So the indications are expanding day by day, and these contraindications are also there, particularly in patients with residual hearing who want to use electroacoustic stimulation. You need a canal. So if there is active infection, multi-drug resistant, TB, particularly in cholesteatoma, if you are not sure of removal of cholesteatoma, this is something need a, I would say something about it. Once you are dealing with a cholesteatoma, your canal wall down approach gives you a better exposure to handle entire cholesteatoma. This approach, subtotal petrojectomy, offers even more exposure than canal down mastectomy, and chances of leaving cholesteatoma is remote. So this technique itself offers a better chance to remove cholesteatoma from every part of the temporal bone. Still, if you are not sure of complete removal of the cholesteatoma, then you can think of, postponing this, or you can monitor, or you can do a subtotal petrojectomy, obliteration, monitor for a year or so for cholesteatoma recurrence, whatever, by means of MRI, fat suppressed MRI or contrast CT, whatever. And if you find there is no cholesteatoma, you can later on implant these patients. So that is a individual call in case you are not sure. Risks are always there, like for any other surgical procedure. Your blind sac closure may broke down. We'll show you how the blind sac closure is done properly. Infection can happen in the fat. Cholesteatoma can be entered, mucoceles. This is very important. I tell you, the most important complication which I never like is the mucocele formation. Exentration of all cells means exentration of mucosa. A little bit rare because I know it can get fibrous, but if you leave a bunch of mucosa, it can secrete mucus and can lead to a mucocele which can get infected and ruin everything. So once you are executing a subtotal petrojectomy, the surgical procedure should be executed properly to exentrate all air cells to prevent any future mucocele formation. So once you are thinking of subtotal petrojectomy, it has to be executed properly. For this patient particularly, let me quickly take you to the CT and MRI findings. First of all, MRI. What all you need to see on MRI? One and only thing, most important, the basic functioning unit. Look at the MRI. See, this is cochlea. You share. Yes. Look at the MRI. This is heavily T2 weighted MRI. Quickly, the patient is ready. See this. This is the cochlea with all three turns. And this is the cochlear nerve coming from the cochlea. This dark cochlear nerve to the subarachnoid space here, to the CP angle system. See, this is cochlea, this is vestibule, this is the vestibular nerve, the semicircular canal. So what all you need to see is whether your cochlea is fluid filled. See all the three turns of the cochlea with bright fluid inside. You can see your scala even on the MRI, the scala tympani and vestibuli, and the scalar partition you can see on MRI, and see this bright fluid that signifies the cochlea is fluid filled. That has to be very careful in patient, particularly post meningitis, who may develop fibrosis, and you will lose this bright fluid in those patients. And secondly, the cochlear nerve running from the cochlea, you can see this on the sagittal section also better. And how can you assess whether the cochlear nerve is intact or not, or it is the small cochlear nerve or hypoplastic cochlear nerve? The best is to go to the sagittal picture and compare the dimension of the cochlear nerve to the other nerves. See, this is, let me tell you, see this sagittal. See, this is cochlea, and this is your cochlear nerve emerging. Above that is the facial nerve. See, above is the facial nerve, this is cochlear nerve, these two are the vestibular nerve. Let me tell you why cochlear nerve. Because this is emerging from the cochlea. You can see in the sagittal and see the dimension of the cochlear nerve. It is adequate. It is more even than the dimension of the facial nerve above. If the dimension of the cochlear nerve is less than the dimension of the facial nerve, then you can term it as a hypoplastic cochlear nerve. So that is something you can see on MRI. And then CT scan, you need to see a lot of things on CT scan. You can see our previous videos on YouTube in detail, but here I'll touch upon quickly what all to be seen. The dimension of the intra-aortic canal, whether it is too big or not. See the facial nerve. See the facial nerve. Facial nerve, horizontal facial nerve. Then the vertical facial nerve. And see in this particular patient, see the mucosa, see the inflammation in the mastoid cavity as compared to the opposite side. Because of this, recurrent secretory otitis media on this side, which we have taken for subtotal petrojectomy implantation today. See the haziness in the mastoid hair cell because of the recurrent secretory otitis media, recurrent infections. So, and the next thing, what you need to see, the cochlea. See the cochlear aperture. This is the modulus, all three turns of the cochlea. Then your facial nerve we have seen. Then your feasibility of the, see, this is the round window here. That's the basal turn. If you go with the regular technique, you can go with this side. Your round window exposure looks good. And we are opting subtotal pituitectomy, and what we are going to do is we'll exenterate all possible air cells. These all possible air cells. We'll close the extraordinary canal here. We'll obliterate the eustachian tube here. See, this is the eustachian tube, the source of infection from the nose. And you have to, what you need to look at the cellularity in such patients, because sometimes they're extensively pneumatized, in which the exenteration of the air cells is always difficult. So you must see how inferiorly the, see this superior inferiorly, this is the cochlea, this is the basal turn of the cochlea, and see below the cochlea the level of pneumatization below in the hypotympanum. See, the petrous apex is not pneumatized. That is a positive sign. Otherwise, you need to drill a complete petrous apex to exenterate all mucosa. So we need not to go to petrous apex that is not pneumatized. You can see the marrow there, and the cavity is also, the mastoid also is not very, very big, you can say, for the exenteration. What important is the cells, the group of cells needed to be exenteration in these particular patients are to be careful, where otherwise you can leave the cells behind, is pericarotid cells. I will show you. See, this is the carotid artery, this is eustachian tube, these are pericarotid cells. Peritubal cells. I will show you how to widen, drill out the eustachian tube completely to drill away all the pericarotid, peritubal cells, the cells between the jugular bulb and the carotid there in the hypotympanum, cells beyond the sinus, perisinus cells. All those hidden areas will uncover and exenterate each and every possible cell and mucosa along with the sleeve of the external outer canal, skin, and obliterate it. That is our goal today for this patient. And then the entire cavity, once we create, will implant and obliterate the cavity with the fat and close outside with the flap, so as to do every possible thing to prevent infection in this patient coming to the temporal bone, to the area of the implant we are implanting. We don't want the infection to come to implant later on, and that is our plan for today. Our case is ready. Any questions before we move, please? In a couple of minutes we are starting. And anybody, any questions?
At present, no, sir. We'll let you know.
Okay, you can learn. And a quick thing about the implant, what we are using today. This is our favorite implant, I would say. And we have Mr. Sagar also from Cochlea. Is Sagar? So the implant today, what we are using is a Kanso 2, the most advanced, I would say, the implant, you can say, available in the market. So the Kanso 2 implant is a most advanced implant with a dual microphone, dual processor for the better hearing in the noise. That is the biggest advantage of this. And this is the first of the year implant processor. The patient need not to use a coil or a BT processor behind. You can use the implant or the magnet of the year, and it can be controlled with a smartphone. It can be recharged with a battery. The batteries can be recharged, controlled with a remote for the volume, bass, treble, and all those basic needs. And the implant is very, very slim. I think the most slim implant, 3.9 mm, and the biggest part is it is MRI compatible. It is 3 Tesla MRI compatible, as it has a rotatable magnets inside. So magnets rotates inside itself, doesn't allow the implant to destabilize. And there's even the external geometry is so smooth to prevent biofilm formation. We like this implant most, and this is one of the best available, most advanced implant you can think of in the present times. The electrode array we are going to use is again a very, very slim perimodular. We'll show you insertion, how easily it is, how one can insert with so much of ease. And I told you this is the smallest and the lightest offset of the year sound processor available in the present context. And you can connect with your phone call, with your Bluetooth, and patient can enjoy direct streaming on phone call, listen music, watch movies, and directly through the Bluetooth or your smartphone. So this is waterproof as well. The patient can submerge at the depth of 3 meters for 2 hours, and rechargeable battery gives up to 18 hours. So these are the basic advantages of the implant we are doing today with the state-of-the-art Kanso 2. And Sagar is here with us. Thank you. And in a couple of minutes, we are starting the surgical procedure. Sir, any questions meantime, if you want? Be back in couple of minutes.
At present, no, sir. We'll let you know.
Okay. So soon we'll be back with the, I'm washing up for the case.
For audience, if you have any queries regarding cochlear implants, please post on the chat box so that we'll be passing those questions to Satish Jain.
Q. Hello?
Yes, sir. Yes, sir.
So our timeout is over.
Okay.
And we are with the case. Are you getting the picture?
Yes, sir.
Now, let me tell you, this approach is simple for the implantation. This is not a difficult operation. What you need to see is a proper planning with the exentration of cells. And my incision is little different than a regular implantation, being a say an inch behind the auricle, little behind, as we have to exentrate more cells behind. Okay. And see, we have to respect the, once you are doing implant, you have to respect the vascularity of the flaps, what you generate, as air is supplied all around by various vessels. Here from behind is the occipital artery and its branches, and inferiorly and anteriorly. Below there is posterior auricular artery, superiorly superficial temporal, and we are not supposed to sacrifice, violate the vascular principles to make incision anywhere. So this is the initial incision, and this is the musculoperiosteal flap which I am going to develop to cover our implant, to secure the implant. And this is going to be superiorly based so that it can cover the implant thoroughly. And we'll be doing a cul-de-sac closure as well, as I mentioned, and that we'll do in the beginning. See, this is the initial incision, and this is how the flap is going to be developed. And for the flap, we want a big flap to cover the implant completely. And my flap incisions are not going to come over the skin incision line. This is important. See, small things are important to prevent wound related problems. If you maintain the vascular principles, the basic general surgery principles to minimize the tissue trauma, minimum use of cautery, and complete flap coverage, and preventing the skin line overriding each other. These are the principles to prevent, the wound related problems. And this is very important because once you're implanting a child, a post-operative infection can be a disaster. See, this is the inferior incision for the flap. This is inferior towards the mastoid tip. Let me know if you have any query, any suggestion, any time. Feel free to interrupt me, sir.
Yes, sir. Definitely.
So this incision, I am going bone deep to take the periosteum along. And as I go behind, my incision will also go behind as I go up. And this is anteriorly, just behind the canal. See that?
Yes, sir.
And see, so far I have not used cautery at all. We have infiltrated, and this is important to minimize the use of cautery to prevent tissue loss. Because if you give too much of the tissue loss, your wound closure may become, very, very tight, very, very tense, and that can invite the wound breakdown. So minimize the tissue loss by means of minimizing the use of cautery. See, this is the periosteum tightly tethered to the cortex. Right. So gently you can elevate this musculoperiosteal flap. And this is how, see this, the cortex is exposed. And this is a very, very reliable flap, you can say, as far as the vascularity is concerned. And see what happens. Leave this behind. See, this is my skin incision line. My flap incision line is there and there behind. The skin incision line is different, flap incision line is different, and they are not going to overcome. My implant is going to come here, and this entire flap beautifully will cover the implant to prevent its exposure. So implant will be doubly secure under the flap and the skin, and that is most important to prevent future infections. The pocket for the implant. Yeah, hold this. Now, at the same time, we have to think of the closure. Later on closure, because the tissue retracts a little bit. So what I will do at this point of time, some undermining of the tissue. And this is done earlier, not at the end of the surgery, as it can lead to some amount of bleeding, and you don't want any bleeding warranting use of cautery afterwards, after implantation. So you can do it now, giving a minute extra. See this? Doing some undermining to release some more tissue. See this? To get a good closure. To give a tension-free closure. See this much. This much of the additional tissue we have secured, so it will not fall short later on. See this? This is very important to, do this exercise at this point of time rather than leaving for later. Because right now, if any bleeding or anything happens to occur, you can use your cautery. Similarly, inferiorly, I will, release some more. Yes. This is good. So the bottom line is your closure should be tension free. Doing some undermining anteriorly as well. Now, section. Before doing any cortical drilling or anything, I will open this canal and do a cul-de-sac closure quickly. Sir, in between, we can take any audience questions or suggestions if they come with.
Yes, sir.
See, this is the canal. And what you have to ensure is that, see, this is the canal which I have cut through and through. See that? That is, and that will bring the sleeve out to give a cul-de-sac closure, and rest this internal skin we will, remove. You have to remove each and every part of the skin there, bipolar. Leaving the epithelium once you are planning obliteration is a disaster. See this epithelium which I am going to remove, just marking by means of coagulation. And there is no epithelium above this, as we are going to pull it as a sleeve for the cul-de-sac closure.
Hello, sir.
Yes, please.
There is a question from the audience.
Yes.
Is there any contraindications for this surgery?
Yes, I mentioned contraindication is active infection. As I mentioned, you have to control the infection before. It doesn't mean that you can't operate in cavities or chronic suppurative otitis media. You have to just control the infection first and then take up. So active infection is one of the contraindication. Second is the residual hearing, and you are thinking of electroacoustic stimulation, hybrid implants, and that requires an exnotic canal actually, and which is not going to be there in this scenario. So, क्या हुआ इसको? We got it. Okay. See now what I have demarcated. This is the skin to be taken out as a sleeve, and this is the skin to be. This is the canal which is need. This is going to be sacrificed. So I demarcated.
Yes, sir.
So there is no confusion later on regarding the skin. It should not be left inside the cavity. See this skin all around.
Yeah, we can.
I'm removing, and this is the bony canal. Why I didn't pull this entire skin out, entire cartilaginous skin? See, I want to not to pull the entire skin out, to give a depression in the cul-de-sac closer, looking like a canal depression.
Cosmetically looks.
Yes, if I bring out this entire canal skin out, it will no longer give a depression. And then it will give the ugly feeling to the patient with the obliteration visible from outside. See this entire thing I have burnt out.
Yes, sir.
Not to leave any possibility of skin, any skin there. What's my point?
Yeah, got it.
Small things are important to prevent future problems once you are doing this surgery. Now is the time, give the suture. We'll elevate this canal and put a cul-de-sac suture quickly. So what you need to do is bring this canal, elevate this canal. Just a minute, we'll take sutures. We'll elevate the sleeve of canal. Completely and suture from outside. Suture. See this canal. I hope the picture is good there.
Yeah, very good, sir.
So only the canal skin is to be taken out. It's very important. Gently, gently, slowly, not the cartilage. See this?
Yes, sir.
And we'll use this cartilage after the cul-de-sac closure. When we bring out the skin together and suture it, we'll use this cartilage as a second layer to reinforce our closure from below.
Oh.
So what we'll do, see the tragal cartilage and the conchal cartilage. You can suture these two cartilages together as a second layer underneath this, canal closure, just to substantiate that this cul-de-sac closure will not break down. If this closure breaks down, again it can, allow the skin to grow inside and can lead to cholesteatoma. So that is something you have to be very, very careful. This closure should not break down. Secondly, once we close, we should use, absorbable stitches, because the removal of the stitches can lead to dehiscence and can lead to breakdown. So Like any other surgery, you have to take care of all possible things preventing infection. See the canal coming out?
Yes, sir. Yes, sir.
Quickly, and we will suture it with a vicryl. See, if it is long, you have to excise. That's what I did medially. You're not supposed to bring out the entire cartilaginous canal. It will be too big. I want this to little bit, we'll push it little bit in to give it a depression of a regular canal. So the entire canal skin is something you are not supposed to bring out. After this, the second role will be to do a subtotal pedicectomy, excentrating everything. And you will see, you'll be amazed to see the exposure you get. Now at the end, you see if there is a cholesteatoma, where can't you remove the cholesteatoma from? That gives the best opportunity to remove every bit of cholesteatoma, the exposure, which is more than a radical mastectomy exposure. See, all these children undergoing implantation should be thoroughly assessed for any pathology which is likelihood to give future infection. And all such cases should be picked up and ideally done a subtotal pedicectomy implantation. Otherwise, what happens if the workup is inadequate, and patient develop infection later on with the implant in situ, explantation is warranted. And a number of patients are are the candidates for explantation already explanted, and that is unfortunate part. And our more and more focus on the workup is the only key. Now this is the cartilage layer.
Yes, sir. Yes, sir.
See, this is the cartilage, the tragal and conchal cartilages will suture together, and that will reinforce the closure from below. So there will be no question of, see the canal again closed from below, being closed. That's the conchal and that's the tragal cartilage. So this is the reinforcement, the second layer by means of cartilage.
Yes, sir.
Can you see? Now
Yeah,
you don't see the canal from below. So it can't break down practically if you say. So it doesn't take long. The cul-de-sac closure, less than 10 minutes. And it is such an effective technique. So this is blocking off important connection of infection, source of infection to the temporal bone from outside. The another source remaining is the Eustachian tube, which will deal effectively. I will show you. And that area is critical as you have a carotid artery around and the carotid, pericarotid, peritubal cells around. So that has to be done effectively again. So this is all about the, cul-de-sac closure part. And now see this flap. Can you put a suture to it? Stay suture laga this. We'll put a stay suture to it. See this?
Yes, sir.
This flap is very vital. Can you put a stay suture anteriorly as well? This is the stay suture. This is another stay suture anteriorly to keep the pinna forward. So majority of the times we don't need a retractor. Retractor is again a traumatic, yeah, sometimes required. So these are stay sutures to keep our area exposed throughout the surgery. See this?
Yes.
Rather than using retractors.
ಅದನ್ನೇ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡಿದ್ರು.
Yes. So this is after the cul-de-sac closure, this is completing the external exposure, and now is the time for drilling. Drill. I hope you are oriented well.
Yes, sir. Yes, sir. Very nice. Clear.
Now, at this point of time, I'll take the advantage and harvest some periosteum also, non-tooth. Periosteum is required at the end of the procedure to seal your cochleostomy, you know. Hello?
Yes, sir. Yes, sir. Now only we will harvest and keep it.
Yeah, I can harvest right now. It's a good fresh periosteum. Cool. Cut. Cut. Yes, that's a good periosteum also.
Yes, sir.
So now we start drilling. Now, drill. क्या करे उसको बोल रहे Look at the cavity.
Yes, sir. Yes, sir.
It looks like you're reaching the upper limit. That is your dura. Looks like the dural plate there.
Yeah, got it.
See the sinus there behind?
Might, yes.
Go. The basic landmarks in view. The canal you have to take. I can do this crude work. This crude work you can go quickly. See all these perisinus air cells. See this sinus and around. Can you see the perisinus air cells?
Yeah, yeah, yes, sir.
Concentrated. This is the sinodural
angle
area. This is toward the tip. See, I am just doing this crude work quickly so that we can, that too with a cutting bar, so so that we can focus to the critical area much better. Now, wash. Each month here. Oh, the picture is good?
Good, sir. Good, good. Very good.
Zoom can you?
Just once, can you just explain the landmarks, sir, for the sake of junior?
Yes, yes, yes. So, first of all, diamond. See, this is the Tagman plate.
Yes.
This is the sinus plate there.
Yes, sir.
That is the labyrinthine block there. There's a part of the canal wall left behind. You have already seen the canal lifted off. This is the anterior canal wall.
Yes.
And that's the, the remaining
Bony
the tympanic membrane and the medial canal, which we'll tackle later.
That's the synodural area.
Yes. Now using the diamond to flush out is all
the
perisinus cells. See this perisinus cells?
So that you are sure of removing all the mucosa.
Exentration of all possible cells is the imperative to subtotal petrojectomy. This procedure, any middle ear surgeon who is well versed with the middle ear work can do it.
Yes.
Believe me, it's not something difficult that people cannot do. It's about, orientation. We have many indications for subtotal petrojectomy in our practice besides this, or many of the lateral skull based procedures, many difficult ears, We are operating many CS1 patients who are profound deaf for implantation and many difficult discharging cavities wherein the patient has already developed maximum hearing loss with no possibility, of reconstruction. This is the answer to take care of the discharging ear. Done once, forget forever.
Completely dry ear.
Yes. This is perilabyrinthine cells. Cutting them. These are perilabyrinthine cells.
Yes, sir.
See the skeletonized dural and sinus regions. This is the facial ridge. Still, I am quite lateral to the semicircular canal. Facial ridge. See the ossicular chain.
Yeah, got it.
Great. Just articulating the joint.
Yes, sir. Yeah.
Move the incus. Circular. See the remaining tympanic membrane.
Yeah.
See the
So there is a question regarding cul-de-sac closure.
Yes, please.
The use of cartilaginous sleeve.
Yeah. Cartilaginous?
Sleeve.
No. We didn't use cartilaginous sleeve. We use the cartilage layer as a reinforcement from below.
Okay.
Sleeve was from the canal skin.
And there's one more question, sir. The type of electrode selection in anomalous cochlea.
Yeah, that depends upon the anomaly. If you have a small cochlea, you have to use a small length electrode. It depends. If you have a ossification, doing drill out, you need multiple electrode arrays, that's a different thing. So that depends.
Okay.
According to the situation. See the medullary structures much better?
Yes, sir. Clear. The eustachian tube opening also.
Yes. See the amount of exposure it is going to give us.
Yeah, definitely.
If you have a cholesteatoma, it gives the best opportunity to remove the cholesteatoma. Bringing the facial ridge to the lowest, to the level of the facial nerve. This is uncovering the hypotympanic region.
Yes, sir.
See the mesotympanum much better now.
Definitely. Definitely. Lot of hypotympanic hair cells are also. So can you just increase the magnification to one step further?
Yes, yes, please. But इससे एक साइड छोटी देना but
Yeah, that's better, sir. Very labyrinthine and retrofacial. Perifacial. What are those cells, sir? Perilabyrinthine, perifacial.
yes, yes. All these are perilabyrinthine cells. This is a labyrinthine block.
Yeah, we got it. Nice. You can see the blue line there.
Yeah, and see this you have to look for any retrofacial cell tract. This retrofacial region anatomy is very important.
Yes, sir. We can't.
The boundaries for this retrofacial, region is, let me tell you, the superior limit is posterior canal.
Oh.
Now see, this is lateral canal. Can you see?
Yes, sir. Yes, sir.
This is your posterior canal.
Posterior canal. Yes.
See the color change.
Yes, sir.
This is the superior limit for your retrofacial exposure. The lateral limit in this is the facial nerve itself. And inferior limit is the jugular bulb. So if you have any pneumatization in this space, you have to go through and remove, and you can come from anteriorly from the middle ear side as well. And that happens, that is required in mostly in the extensively pneumatized, temporal bones. Here I am flushing everywhere.
Yes, sir.
This is supralabyrinthine. See the superior canal.
Yeah, it's
all three canals skeletonized. Can you see?
Yes, sir. Yes, sir.
This is supralabyrinthine region.
Yes, sir.
See that? Section bhi chota there. For everybody, this is posterior canal, this is lateral canal, and that is superior canal.
Very nice.
I hope it is very clear. Visible to everybody?
Yes, sir. Yes, sir. Very clear.
See what I am doing, accentrating the supralabyrinthine.
Yes, sir.
Can you see thoroughly?
Yeah, clearly.
Each and every cell tract visible is being followed. That's the facial nerve coming. That is the anterior atic region now. Oh. Yes. It's body there. See my facial nerve all the way from here to here going. That's the stylomastoid foramen level. See the posterior part job almost done.
Yes.
Can you see clearly?
Yes, sir. Yes, sir.
That's the facial nerve, complete skeletonization, bony skeletonization. See that? Now, coming further anteriorly, this bone anterior to the facial nerve to expose the posterior mesotympanum better. That is processor cochleariformis. Look at the hypotympanum. Now give me bipolar. See, wherever possibly you have doubt of any mucosal, remaining mucosa.
We have to
Anywhere. First of all, drill, excentrate, or you have slightest doubt of any kind of soft tissue, could be epithelium, could be mucosa. Not sure. Devitalize.
Yes, sir.
Devitalize means burn it out. Make it non-functional. Can you see?
Yes, sir.
Make it non-functional.
Yes, sir. Yes.
Drill.
For the sake of juniors, just delineate the horizontal and vertical portion of facial, sir.
Yes, it is very clear. Let me show
Yeah.
you.
With some pointer, if you can show,
Yes, yes. Super.
starting from the geniculate ganglion.
Yeah, I will go that region, but it is coming from here. See, this is the horizontal portion of the facial now.
Yes, sir. Clear.
See this? Arching over the whole
Second.
window. And then give me the diamond. Let me make it more clear for you. Gentle diamond burr. Can you see the facial canal better?
Yeah, definitely.
See the facial now. See the vertical course here.
Yeah, clear, sir. Clear.
Going to the xylomastoid foramen. And now looking at this, all bone anterior to it. This is called anterior thinning of the facial ridge. See this?
Yes, sir. Clear.
To look into the mesotympanum much better. Posterior mesotympanum.
Posterior mesotympanum.
Now this is process of cochlear formation. This is hypotympanic cells, you can see. Now this is my eustachian tube orifice. See, I have to effectively block the eustachian tube. Hello?
Yes, sir. You're
Now let me show you.
widening it.
Oh, the elevator. See now, some landmark there in the eustachian tube area. Can you see this cochlea there?
Yes, sir.
Promontory?
Yeah, promote.
Just above that is the canal for the tensor tympani going anteriorly.
Yes, sir.
This is your facial now.
Process of cochlear.
See where the cochlea is ending. What is there in the floor? See this?
Yeah. Yes, sir.
Carotid artery.
Carotid.
Yes. That is all carotid artery. See the eustachian tube?
Yeah, clear, sir.
And in
Clear.
the floor of the eustachian tube is the carotid artery. What I will do to effectively obliterate the eustachian tube, I will do this lateral widening of the tube first. So uncover the eustachian tube. The bony eustachian tube is just a centimeter long.
Yeah.
Cartilaginous is much longer. See, this is all promontory mucosa. This is your tensor tympani I have taken.
Yeah.
My facial nerve is above. This is all tensor tympani. See, this is muscle.
Yeah, we can see, sir.
I drilled because of the mucosa over it, and now it is. That's it to it. See this mucosa? See the tensor tympani gone? Diamond. So look at the diamond bar. I'm working right over the carotid artery. See, widen it. All peritubal cells, widen it thoroughly. See that?
Yeah, clear.
Thoroughly means thoroughly. Can you see the carotid artery below?
Yeah, that white
It's
partition.
bluish hue.
Yeah, yeah.
This one.
Yes, sir. Clear.
See all this mucosa around the carotid.
Of
This is
eustachian.
pericarotid cells here and there up.
Yes.
See how much the eustachian tube has orifice has been widened. See all these mucosa have been revitalized.
Yes, sir.
See that how big the eustachian tube orifice now is?
Here.
This is peritubal cells. What now I am accentrating? See this mucosa? This is possible only after widening the eustachian tube.
Otherwise, we will miss that.
Pardon?
Otherwise, if we don't widen the opening, we will miss those peritubal cells.
Yeah, and you know what happens? These cells may open up.
They'll start discharging.
A distance in the tube. If not removed, a CSF coming to these cells can come in the eustachian tube at distant place.
Oh.
So peritubal place cells. See now, all
Yes.
pericarotid cells.
Clear, clear.
See, I'm running over the carotid artery. See all cells?
Yeah, yeah.
Oh. Now, no question of any peritubal or pericarotid cells. And this you have to ensure on table, you know.
Yeah.
By skeletonizing. Now, having done this, everything cauterized, that's a part of the mucosa and all. We'll push now everything, all this soft tissue
Inside.
inside the second tube and obliterate it. That's it for this
That
part.
gets fibrosed and
For this part. See this?
yeah, clear.
So almost completely, we have a habit of drilling the bony second tube. So all this mucosa can be effectively removed, and second tube can be effectively packed then only.
Yeah. Any other material like soft tissue, anything to be plugged, sir?
Yeah, any soft tissue. Best is muscle.
Muscle, yeah.
You can use any bone tissue into it. You can use bone wax along.
Oh.
See, now that region is over.
Yeah, clear, sir.
Yeah. Yeah, that is the marrow bone. You need not to do anything.
Yeah, marrow. It's oozing.
See, what is this bone? Anybody? This is petrous apex.
Yeah. We saw the marrow on CT.
I told you on CT scan that is a marrow bone.
Marrow, yes, sir.
These are not
No
hair cells.
cells as such. Not pneumatized, but
yes, you
marrow.
don't need to do anything. Now, coming to another region, very soon we'll be through with the petrosectomy part. And then will be implantation soon. Now the clearance of the hypo and posterior mesotympanum. What is there below? Anybody? Blue issue?
Bulb, jugular bulb.
Yes. Can you see the round window region?
Yes, sir. Clear.
And see, these are the cells below the round window. Cochlear canaliculus. Now, give me the bipolar. You have to skeletonize the jugular bulb thoroughly. You have to skeletonize the cortico-jugular sulcus. Once you are doing subtotal petrosectomy, it should be a dedicated work to exenterate all these critical areas of the mucosa. See this?
Yes, sir.
All these areas my bipolar can take care of.
So there is a question, sir. Choosing of the size of the bird tip and type of bird.
Pardon?
That the bird tips and type of birds. What size
you
you will
need
use.
variety of bird tips and variety of bird lengths. I will show you at the end our toolkit. We have more than 50 birds for the cochlear.
Short shaft bird tips.
Yeah, all these are long tapering shaft.
Tapering.
Yeah, long tapering, long tapering.
So that we can see the tip.
Can you see this shaft?
Yeah, yes, clear, sir.
Long tapering, so it doesn't come in the way.
We can see the tip clearly. Where we are drilling it. Sir.
See the hypotympanic clearance.
Clear, sir. Very clear.
And that is your round window.
Yeah, very good.
See, with this exposure, imagine the implant insertion would be so easy.
Clear.
That would be no more a challenge. See that?
Yes.
Yeah, that part is now ready for implantation. See this?
Handpiece.
And now.
Sir, how about using a contra angle handpiece? Sir?
Yes, at times you need. At times you need. It should be part of your armamentarium, you know.
Yeah.
Body. See how the cochlea is skeletonized.
Yeah, clear, clear.
See the carotid artery skeletonized, the Eustachian tube, that's the Peters apex area, that's the cochlea, that's the jugular bulb and the hypotympanic area. Behind retrotympanum, round window.
Very clear. Sir.
And see, this is the area of the crotch between the carotid and the jugular.
Jugular.
See, you can see very clearly now. See the crotch. Can you see very clear?
Yes, sir. Clear, clear.
Body there. There should be no hidden area left behind. Now, if somebody asks, I've been asked earlier, while doing cholesteatoma surgery at the same stage of implantation, how will you ensure complete epithelial removal? With this kind of approach, this kind of, exposure, how can somebody leave the epithelium behind?
With this much of exposure, definitely we'll be sure that we are not left any epithelium or cholesteatoma behind.
See the entire jugular bulb, carotid artery and the crotch?
Yeah, yes, sir. Very nice.
Any doubts?
No, sir.
So that's completely skeletonized?
Beautiful. Yes, sir.
So now coming to the upper part and lastly toward the oval window and then implantation.
Now there is a question, sir. Which is better, cochleostomy or round window insertion?
To me, this question does not exist and I don't want to fall into this controversy. Let me tell you our philosophy. I will show you how cochlea is aligned in a normal human being with the cochlear turn starting where the round window is, forming the posterior, backdoor intro into the cochlea. The
Yes.
cochlear turns antero-inferiorly. Okay?
Yes, sir. Clear.
If your round window is favorable and facing the antero-inferiorly, you can go through the round window. If it is not, if the round window is only antero-posterior, your implant, if you try to push it, will going to go and push the modulus, hit the modulus. So then you have to remove what we do, we remove the inferior wall of the round window. Started the stapes region.
Anterior floor.
Yes. Scissors. I generally use laser for this because it's a mobile. We'll cover this. Give me a soft tissue. I generally use a laser. Hello? Hello? Hello?
Yes, sir. Yes, sir. We are.
Generally we use because we have to remove the stapes, this, height of the stapes as we have to obliterate the cavity. So generally we use the laser.
Right.
Without mobilizing it. If laser is not available, then you have to obviously.
Is the periosteum which you harvested?
Yes, a little part of it. See this?
Right. Clear.
Yeah, doesn't make any difference. Now, see all these mucosa around. Hold on. See all these mucosa around.
Pyramid.
And that completes our now
Yeah, Karthik.
subtotal petrosectomy.
Good afternoon.
Hello. Hello.
Hello, sir.
Yes, yes. You were asking something?
No, sir. No, sir.
Just to cover up the foot plate. See now my subtotal petrosectomy is complete.
Yes, sir.
See that? Everywhere. See the marrow.
You want to plug that marrow with any periosteum?
Yeah, but that will. This is the marrow bone. This is the Peter's apex region.
Surgery.
Just for a minute, we'll leave it. This is just marrow bone which bleeds normally. Okay. Surgery, sir. No, there's a shorter cotton ball. Okay. So now, for the cochlear implant point of view, I have to open up the cochlea and push the implant. That's it. From this side. Now we'll make the bed for the implant.
Okay.
And then do this, cochlear opening and implant. See the rest of the field?
Yeah, clear, sir. All clear.
See now?
Yeah, very nice.
This is what subtotal petrosectomy is. You have to excentrate. You have to track the cellularity everywhere. It's cotton there. See this?
Yeah, clear.
Anybody, any doubts, please come forward. See this, all area perfectly under view. Everywhere is bony plate. See the facial now, periosteum behind. This periosteal bleeding. I would never use cautery over it. Can you see?
Yeah, clear. Yes, sir.
Just leave it. You adrenaline ball. Just leave adrenaline ball. That's it. So now quickly I will make the. Is Ranju come?
Bed for the implant.
Yeah, bed for the implant. Yeah, give me. वो देना template देना. ये भी खोलना. तू था. So I am otherwise far off from the place, but just you can see this template is actually not required in this because this, this is off the ear implant. But yes, in future he wants to change. See, I'm going to be quite away from this anyway. Leave it. Now, utha. Now this is a very, very slim implant. I told you. This is a very slim implant. Hello?
Yeah.
Hey. Yeah, and this is, I told you, this is just 3.9 mm. So this is ideal for the children, for the thick, thin bone over it, thin skull bone. So many a times you don't actually need to go right to the level of the dura. Since it is a thin profile, the 3.9 millimeter, and see the skull of the child is so thin.
Yes, sir.
Otherwise, you don't need to go to the level of the dura. Sana? Oh. Without giving any extra pressure, I am using the cutting bar. No pressure at all on the bar. Yeah, this is important 5-minute job. This is important for the implant to secure the implant. There are many ways to secure. You can use a periosteal technique or you can use a tie down sutures. We prefer tie down suture for a more secure, position to prevent the implant migration. Most importantly.
Sir, there is a question. Post petrosectomy, how to monitor epithelial growth in the cavity?
Epithelial growth.
Yeah.
Yes. That is important when you do any obliteration. You don't want epithelium inside. And this monitoring mostly done with the MRI. And post implant, this is again a big problem to get MRI again and again done.
Yes, sir. Yes, sir.
So a diffusion weighted MRI can tell you exactly if anywhere developing. And in implant patients, getting MRI done is a big problem. Sometimes you need to remove the magnet. But in this particular implant, this is 3 Tesla MRI compatible. So you can monitor. Ideally, according to the Mariosana, we must monitor these patients up to 10 years, 1, 3, 5, 7, 10 years to see any, to any epithelium developing. Secondly, if you don't get the MRI done, sometimes even a contrast CT scan will differentiate if any such thing is happening. And in that scenario, in that scenario, what you can do is, if anything is happening, you can monitor with the CT, but it is increasing in size. It could be definitely something. And then obviously re-exploration. But that can be almost certainly avoided by the good surgical technique. With this kind of exposure, imagine, can somebody leave the epithelium behind?
No, sir. Clear.
Who is the implant surgeon?
Yeah, perfect.
I hope it is fine now.
Fine, fine.
Yes, sir. It is
Deepak
fine.
sir. Deepak sir.
Malik, that area that you taught, near the eustachian tube, we need to widen it, do bone work to remove the mucosa. Fantastic. Because generally people tend to
see eustachian tube area clearance is very, very important. Now we'll make tie down holes.
try to remove the mucosa.
Yeah, important is mucosa. Your point is valid,
Satish.
sir. Yes, sir.
Right? I think a lot of them are scared of injuring the dura and getting a CSF leak.
Yeah, if you have.
Otherwise, I feel tie down hole really makes it secure.
First of all, the answer is, see what I'm doing. Protecting dura.
Yeah, yeah, yeah.
So CSF
I think
leak is happen.
basically you
If still CSF leaks, can't hear you, sir.
creating a plane between the dura and the bone.
Yeah, still if CSF leak or such thing happens to occur, you have to close it same time like any other CSF leak we do. Nothing special, but see this, protect your dura. That's it.
No, keeping the elevator like that protects the dura.
Yes. Sit down. Now we'll put our thread into it
Good
and
step.
open the implant. And now implantation, out of the entire surgery, the simplest part is, I tell you, implantation. Believe me. And that too is much easier with this Canso 2. Cancer to implant is the easiest way of implant insertion, I tell you. That too perimodular, slim modular implant. Slimmest of all, 0.35 mm is the tip and goes perimodular, unlike previous perimodular implant. Why perimodular? You want to stimulate the spiral ganglion cell population closest. As it stays around the modulus, your battery use is minimum, you can say. You know, earlier, when the blind insertion was very common, like many surgeons, just pushing the implant inside the cochleostomy round window may not go adequately at the right place. Many a times we have done workshops to show the intracochlear anatomy regarding implant insertion right in the scala tympani. We must be well versed with the anatomy of the inner ear. We must be well versed with the anatomy of the inner ears for implant, preferentially go in the scala tympani. If you are not aware with the anatomy and in pushing the implant blindly, it may go into scala vestibuli. Earlier studies have been done for the implant lying in the scala vestibuli, and that is something produces the highest level of intracochlear trauma, because in order to implant to go into the scala vestibuli has to fracture through the osseous spiral lamella.
That's right.
And then it is going to produce you the highest level of intracochlear trauma. An implant lying in the scala vestibuli is farthest from the spiral ganglion population cells, and then you need more current to stimulate your neurons. The more current can cause problems also if your facial nerve, sometimes your bone is thing, that is most often in autosclerotic people. Otherwise can lead to facial stimulation if the nerve is in vicinity. Exposed to so many problems. Best is to ensure implant going in the scala tympani. That's it.
But your extended round window approach ensures that, no?
Pardon?
You have taught us that only. Your extended round window approach,
Yeah.
which
So
you
what
have
we'll
taught
do,
us,
we
ensures
will
that
make
only.
the
Yeah.
we will make the straight tunnel into the basal turn. आगे था यार, forceps. So the insertion should be in a scala tympani, and that's the simplest way. I will show you. I will show you the straight tunnel of the scala tympani. All you need to do is remove the inferior wall of the round window, inferior wall, widen it inferiorly. It will open up straight into the tunnel of the scala tympani, rather than going to the round window when particularly it is directly anteroposteriorly placed. So if you push the implant, it is going to hit there to the modular wall. And once the implant hits any wall, it may curl around anywhere. And then these all fragile structures like osseous spiral lamella, basal membrane, anything can be ruptured. So the implant should move in the lumen, and that you have to decide intraoperatively with your trajectory. What the peri-round window insertion or cochlear insertion or round window, whatever. It should be a trajectory straight into the lumen for the implant to go. That is bottom line. Yeah. Now this, this is a tedious job sometime, but it is very important for the implant to secure. Other technique is the periosteal, technique, the periosteal ridge pocket, but this is, we feel more secure. That's it. Now, can you open up the implant? 1 minute, bas. Oh, bana do. Opening. Hello? Hello? Hello, sir?
Yes, sir.
Hello?
Yes.
Yeah, tell me, Satish.
Yeah, Deepak sir, now coming to the point what you were saying about the implant trajectory, how it should go into the scala tympani directly.
Yeah, this is very important. I think in the first stage, some of the implants were going into the scala vestibuli before we learned this extended round window approach. Isn't it?
That's why
Yes,
your
yes.
trajectory, you should be able to see your, the lumen of the cochlea.
Correct, correct. And that's why some people required more current and they had giddiness. Some of them had facial stimulation.
Now, can you see my round window area?
Yes, sir.
Yeah, yeah.
See what I am doing. See now. See my trajectory now. See round window, the part of the round window is above.
Yeah.
And see the implant trajectory now. See the lumen. See the lumen directly, tunnel.
Yeah, clear.
Yeah. It's a 3D tunnel, Satish. Now we can see.
Yes. See the tunnel?
Yeah.
Yes, sir.
Very clear.
It is like a tunnel. You don't need to, now whatever I push, it is going to go straight in the lumen inferiorly. The direction is inferiorly. We wash with the Dexona also. This is Dexona. See that?
What is your take on Helon? You don't use Helon, no, Satish?
Helon can be used, but Dexona is good to protect the
Okay,
intercochlear
okay,
structures.
okay. I think now everybody believes in the Dexona pool, isn't it?
Yes, that's the implant.
Yeah.
Now this is Kanso. It is an implant inserter. It is a tool to insert the implant.
One big advantage of subtotal petrosectomy is the ease of visualization of the round window.
Yes, yes. Now I told you the implant insertion is a child's play now.
Yeah.
See now everything is
Unlike a
in front of you.
posterior tympanotomy.
See, this technique gives you the best opportunity to identify the structures in difficult anatomical situation. If you have a difficult anatomy, do subtotal petrosectomy because it gives the best opportunity to identify structure.
Yes.
See now, no bleeding anywhere.
Yes.
Yeah, give me a little bit. So before opening the implant, what I'm doing,
Cauterizing all the bleeders.
in case required, anywhere, ensure now rather than, because it is not advocated by the companies to use the diathermy after that. The bipolar is safe. Even studies have proven that even the unipolar is safe most of the time. But why to violate?
Yeah. The stakes are very high.
Law. Now see the implant.
Yeah.
So you can imagine how slim the implant is.
Yeah.
Yes, fix.
And anyway, you're putting nice tie down sutures also.
Yes. With this implant, I want to be very tight.
This makes it doubly secure. You made a well as well as the tie down sutures.
Yes, sir.
Satish.
See, implant migration is a disaster. So we have to work on it well. Yes, sir. You were saying something.
You must be one of the surgeons who do two rare things. One is subtotal petrosectomy for implantation, and second, the tie down sutures.
Tie down sutures. I don't know. A lot of people must.
सच्ची नहीं शुरू में कितना हम लोग करते थे. When implants came first in the country, I'm sure tie down sutures were a rule.
Yes.
Nahin? This is an important step.
See, this
Moving
is
the stitch
important.
away from the wound. Yeah.
Yeah, away from the skin, the subcutaneous
Yes.
tissue. If they project,
Yeah.
they poke into the skin,
Yes.
can be again a disaster. You can invite
Yes.
infection.
And then flap necrosis is one of the worst disasters again.
Infection.
Yeah. Yes.
Elevator. Just to make sure this doesn't come out. See this? Just to make sure that this doesn't come out.
Yeah, that's another interesting step. I was rotating the suture, but I was not keeping the surgicel.
This is to keep in place. This invites fibrosis and this remains in place. Now it is submerged. See this? You cannot allow this to come out now.
Yes, boss.
I don't want suture to project and come at this.
जैसा तू हमेशा बोलता है ना, एकदम तगड़ा.
Sir. Now, this is implant. The final insertion. Again, this implant is a very good tool to insert. We'll show you. This is the ball electrode. This is ball electrode to go underneath the muscle. This is going to go underneath the muscle. Now.
The ground electrode, isn't it? Yeah.
Yes, yes. We put the Dexona in the cochleostomy. Meanwhile. Now. See the beauty of this insertion tool. Let me tell you.
The direction of the flange.
Yes. Then. That is fine. Hold करने को force. See now, can you see the implant array, electrode array?
Yes, sir.
Yeah.
This is electrode array. This is the inserter. See, I am loading the implant inside. Can you see? Can you see I am loading the implant inside?
Yeah.
Again,
Yes, sir.
Look at the curvature of the implant towards the modulus. We have to keep it towards the modulus. We have to keep it towards the modulus.
Yes, sir. Okay.
Okay. On the right side, I would keep it opposite. Okay.
Fine.
I hope it is clear.
Clear.
Yeah.
Now see. With this inserter tool, the life is so easy now, as you have to just push the implant inside. Your cochleostomy should not be too big.
Sir, can you a little bit zoom in, sir, so that we can see?
See, you have to keep it there. See this guard. See, there is a guard over it.
Yeah, got it.
Can you
Can
see
you
here?
zoom it, sir? Can you zoom it little bit?
Let me. Come. Yes. Can you see the
Yeah.
guard over it?
Yes, sir. Yes, sir. Clear.
This is to protect that this should not go too in. This. And to ensure that your cochleostomy should not be bigger than this to push this guard inside. Okay?
Yes, sir.
Now put the guard and slowly push your implant in. Can you see?
Yeah, clear.
Yeah, that's the lock. See the both white marks together?
Yeah, clear.
Could you see clearly?
Clear, sir. Clear.
First I fixed my right hand, now I'm fixing my left hand. And bringing the sheath out. Can you see?
Yeah.
Very clear.
And see the white mark at the cochleostomy. Okay. Look at the white mark at the cochleostomy site.
Yeah. Yes.
See that?
Yes, clear, sir. Clear.
See the two white marks right at the cochleostomy site, signifying the complete insertion. Could you see?
Yes, sir.
That is the beauty of Kanso. Now this is my periosteum all around.
So this should be done slowly, isn't it? How many seconds you would recommend for the insertion? 15 to 30 seconds, or just to be done slowly?
Yeah, it should be slowly. Actually, the concept behind slowly is, idea is you should be at the in the right trajectory at the right level. So that if you go fast, otherwise you can damage the intercochlear stem. You can damage, if you go wrong, you can hit the osseous spiral lamella and then the damage. Slow means you should have a feel that it is going smooth. Number one, it is not having any obstruction anywhere. You're not finding any resistance anywhere. You can have that feel then only. If you are going fast, you can't have that feel. See now?
Yes, sir. Clear.
Soften. See my cochleostomy, very well set. Hello?
Yes, sir. Clear.
Secured with the periosteum. And we'll do NRT also. I'm just securing my periosteum with a couple of, marrow cell sponges. Marrow cell is a beauty, acquire blood, swells up more than the volume of the marrow cell and gives a good pressure.
Gel form?
Just gel form, sorry, not marrow cell. What I said, marrow cell.
No, you said gel foam only.
Yeah, gel form, sorry. I spoke marrow. Impedance. Now see, had there been a situation of a CSF leak, suppose you are doing a malformation or anything, what else then would be a better situation than this to handle the CSF leak? What else would have been? Imagine. You have everything, all,
But for this, you have to be confident of removing all the epithelium properly, na, Satish.
Not only epithelium.
So you should know how to do a good subtotal petrosectomy.
Yeah, that's what I demonstrated. Not only epithelium, mucosa also. Epithelial removal is the easiest. You see epithelium differently. Mucosa removal requires cellular exentration. See, to exentrate the cell, we had to skeletonize what not. See the Eustachian tube, the carotid artery there, see? That's the carotid artery skeletonized. The jugular bulb behind, cochlea skeletonized, facial nerve, everything.
Yeah.
So now we'll take NRT. In the meantime, after that we'll obliterate with the fat. I'll show you how the fat pieces can be placed to prevent dislodgement of the implant. So that will be additional, a boom to prevent implant migration. So the advantage, the exposure. Number two, in situation of CSF leak, you can control by the best way. Number three, to secure the implant in place to prevent the implant migration, electrode array migration is the best. I will show you when I obliterate the cavity with the fat, how it protects. So that is the advantage. Now we have blocked the Eustachian tube completely. We have closed the external canal from outside, and we are obliterating the entire array, covering the entire array with the fat and obliterating the cavity with the fat. Now, where can the infection come from? Practically, we blocked off all sources of infection to the temporal bone and the implant, electrode array, everywhere. And see what we sacrifice the external and middle layer, how the external and middle layer are useful when you are using implant. They are of no use as far as the hearing is concerned. But this gives almost certainty of preventing future infection. There is no other way. Imagine the situation if the child, anybody operated and developed CSOM later on with the implant in place, and how to face that challenge. Antibiotics generally do not work in such situation with the infection there in the vicinity of a foreign body. It acquires biofilms. No antibiotic works. You can try removal of the biofilm. It can work sometime with, vascularized flap. We have done a number of times and we have been able to save some implant, but it can come back. So this is the final answer to prevent infection. An implanted child doesn't need external middle ear. His hearing is electrical now. And if we do this procedure, you can almost certainly block off all sources of infection. This is evidence-based, proven. Mario Sana is probably the highest series in the world doing subtotal petrosectomy implantation. And the goal is, the stakes are high, as Deepak sir said, in such a child,
Because once an infection occurs, it is really dreadful.
Ultimately,
and
you'll have to
biofilm
explant.
formation is also dreadful.
Ultimately, you'll have to explant. The mental and financial trauma to the patient, it is bothersome to surgeon as well. In spite of having done good job, the unavoidable complication is set in, and this is something not desirable by anybody. So as to prevent infection for short in future to some area, what we have created is a sterile zone. Now where the implant is lying, where it is lying in a sterile zone all around, with the fat all around, with all sources, all outside sources of infection which can travel inside blocked. Yes, of course, it is a bigger procedure than a regular implant. It calls for a good subtotal petrosectomy, a good surgical technique, but that is all expected from a surgeon to do.
But the degree of safety it also gives, and the drastic reduction in extrusions and explantations, I think it's worth it in special cases.
Hello? Hello?
Yes, sir.
Yeah.
Yes, sir.
Hi, Satish.
Yes,
Hello.
madam. Hello.
Hi, Satish.
Hello, madam.
Actually, they had asked, the host has asked to rank your surgery. I think it is A plus to the infinity. Fantastic surgery, Satish. Enjoy. The online as well as the offline is full.
Okay, I understand. We can, my job is done and we can disconnect the transmission now. We are doing NRT. We just have to, once the NRT finishes,
Yeah, you
obliterate
can
with
just
the
show
fat.
the NRT.
That is not a very, very crucial procedure, obliteration anybody can do. So we can, if you think we can disconnect.
You are also filling it with fat now?
Pardon?
You are filling the cavity with fat.
Yes, yes.
After this, after the
next
NRT?
5 minutes, next 5 minutes. I can see Hetal on screen. Hi, Hetal. Hello. Hetal.
Hello, sir. Hello, sir. Satish, sir. Thank
Yes,
you very
sir.
much for a wonderful demonstration, sir.
Thank
And,
you. Thank you all for giving this
auditorium,
opportunity.
nobody moved out of the auditorium, even for the lunch.
Yes,
Oh
sir.
my God, I spoiled
Parallel
lunch.
surgery.
And they're all giving you a standing ovation.
Ovation
Sir.
to you, sir.
Thank you, Satish.
Thank you very much, sir.
On record, you have been my cochlear implant mentor.
Sir, you are mentor to many, sir.
That is now. But you have been my mentor for the first 5 cases. How can I forget that?
Hello, Hetal. I can see Hetal on screen. Can you hear me, Hetal?
Yeah, she is there for the oration.
Hello.
We'll shift to the oration, sir.
Okay, okay, sir. Thank you very much once again. Please carry on.
Thank you.
We'd like to call forward Dr. Loknath sir and Dr. Munish sir to present the mementos to the moderators.
Right, good. Thank you.